on retina also, because we have a lot of residents here, and this is the request to make webinar for them also. And I just planned the webinar in such a way that some very important topics and very important issues will come out, and it will be asked in the exam also. And very important, sometimes the lot of webinars is going on, but still a group of people are very much interested about this webinar.
Very true. No, I think this is going to be the future. I think a lot of physical meetings, even when possible, will go down drastically after this, because this is so much easier and so much more rewarding also.
Yes. No doubt.
Very true.
So your topic is okay for you? Because
so I've compiled few common things that can go wrong, from capsular excess till stromal hydration. So
fine.
One example for all situations. So,
okay, that's really very good. And also from the next month, we will also start a webinar from the SARC Academy of Ophthalmology. I'm also a council member. So from the next month, this is a good organization, and there Professor Rajvardhan Azad, Dr. Namrata, Dr. Lalit Verma is there, and they will try to make it very good. So.
No, SARC it's always been a very reputed sort of meeting. SARC meeting.
So how is sir?
He's all well. He's in fact first month or two were difficult for him to stay at home, because he's never done that for so many years. But now he has gotten used to it. He's in fact spending so much time on exercise, fitness, and things that.
Oh my God, he's so fit. He's so fit.
That's what. So he's in fact feeling now getting back to work after 3-4 months. If it goes back to normal, will be very difficult for him.
Yes.
Very true.
So what about the All India Ophthalmological Conference? Is it going on?
Officially, no announcement has been made, but unofficially, everyone knows it's not going to happen in the physical form. And it will be a very sort of large-scale virtual meeting. Like some of these conferences now have these virtual halls and, multiple halls going on at the same time. And
like WOC. WOC. That was really excellent arrangement, no doubt.
Correct. So it's going to be like that only. They haven't still officially announced it, but it's going to be
but we will miss this All India Ophthalmological Conference.
Very true.
Because I like it so much, because I used to go to the different countries, and I am European country and different, but still I love any conference in India. I don't know, for your hospitality and everything. It's really very good.
Hospitality and all the local flavor of each city is so different. Food, all of these. Europe, whether you go to one country or the other, it's the same, Yeah, everyone is going to miss the physical meeting, but I think at least in the first half of 2021, I don't think there will be any big physical conferences.
Should be. I had all planned, and I had made a group of almost 50 ophthalmologists from Bangladesh, and to go to the South Africa World Ophthalmic Congress. We had a group meeting there, and society meeting there. I was also invited speaker there. We had and I have planned with my family South Africa. We will go to the Dubai, then South Africa, then we'll go to the Zimbabwe, and then come to the Bangladesh. So we had a large plan, huge plan. Assalamualaikum, Shaukat bhai.
Alaikum assalam. Good evening, everybody.
Good evening, sir. Good evening.
He's Dr. Shaukat Kabir, is our General Secretary of Bangladesh Cataract and Refractive Surgery.
Wonderful to meet you, sir. I was just talking to Dr. Sham that I saw all the links of the webinars on YouTube and Facebook, and phenomenal work in the last 3 months or so that has been done by the entire team of all of you. Super.
Yes, thank you.
it is a tremendous development through worldwide also.
Yeah. Tremendous. I mean, because anywhere where the content is good, people always look to, use it. Yeah.
Yeah, because the opportunity is much more now. Because
Very true.
earlier day we have to go and see you people and to know more about. But now we can communicate from my end or my home or office also. It's a, I think it's a
Okay.
great opportunity.
Hi,
Good
sir.
evening, sir. Good evening, sir.
Good evening.
Good evening, sir.
Good evening, sir.
How are you?
Fine, sir. How are you?
I'm
How is
fine,
going,
fine,
sir?
sir. How are you, sir?
Fine, sir. Thank you very much. I'll be back in 2 minutes, sir.
Okay, no problem.
Okay, thank you, sir. Thank you, sir.
I just
No
finished
problem.
a Rotary webinar.
Yes.
I'll be
sir.
back in 2 minutes.
Okay.
Okay, sir.
So
Yes.
there are a lot of webinars.
Yeah,
I,
Saturday,
I,
Sunday, these days it's morning to evening webinars.
yes. I have just talked to Professor Natarajan to make a plan on the retina webinar. And he was telling that he has been with the webinar for the last 6 hours. 3 different webinars. And, Natarajan is always, he's full packed with the webinar.
Yeah,
One by
yeah.
one.
And he's equally, energetic in all of them. It's not chalo by the end of the second, third webinar, he'll be just in between coming and going. He'll be equally participating from
Yes,
A
yes.
to Z everywhere. Yeah. Tremendous energy, unbelievable energy. Yes.
Unbelievable energy. Yes.
জামি ভাই চলে আসছে জামি ভাই অলরেডি প্যানেল ইয়েতে আসছে অলওয়েজ হি ইজ ভেরি মানে ফার্স্ট কামার হাসান জামি মানে অ্যাজ এ actually Dr. Sail
Yeah.
in our country direct participant is less because we don't have any registration but usually we just very quickly we just share to our Facebook different groups
Right.
and
Very
most of the people used to see through the Facebook and
Facebook
YouTube.
or YouTube. I think even I do the
YouTube.
same. Whenever there is any webinar and I'm seeing, I usually go to YouTube only and see it live.
Yes,
Yeah,
because
instead of-
and I used to when I miss one thing, I just share in my page and I used to see in the later.
Correct. No, that's very true. I think YouTube and Facebook have really changed the way people look at.
Assalamu alaikum, sir.
Yeah,
Good evening, sir.
Good evening.
Good evening, sir.
Good evening,
Thank
sir.
you,
Good evening.
Basavada is with us. Shall Basavada.
Good evening, sir.
Good evening. Yes.
Great to be here.
Okay. Thank you very much for joining us.
Sir,
Sir,
bye.
sir is our society president, and
Sir,
he is
I
also.
know. I
We met earlier.
Yes, sir.
Thank you very much again. Yeah. Thank you very much.
Thank
Dr. Mohan Rajan is on the way to join us.
Dr. Mohan Rajan has already joined, sir. He will
Okay.
just rejoin after 2 minutes. And
Okay.
I have just talked to the Professor Sajdev and Professor Namrata. They
Yes.
have another, today is Sunday, they have a lot of webinars. And they will join and they will go and then they will come back.
Okay, fine.
They have a collaborative webinar with JAIS, I think. Dr. Shail?
Yes, it's All India Ophthalmic Society webinar sponsored by
yes.
Zeiss. It's on trifocal IOLs.
Oh, yeah.
Trifocal IOL.
Okay.
তবে স্যার আমাদের রবিবারে ওয়েবিনার আমরা অ্যাভয়েড
আর
করাটা
রাখা
ভালো
যাবে
হবে
না, হ্যাঁ।
রাখা যাবে
রোববারে আর না রাখাই ভালো।
ভালো হবে, হ্যাঁ।
আমরা মনে হয় বৃহস্পতিবারে রেখে পরেরটা।
হ্যাঁ, পরেরগুলো বৃহস্পতিবার করে। স্যার ওই যে আমি স্যার আজকে ওয়েবিনারটা শেষ হওয়ার পরে আমি ওই যে ডক্টর প্রফেসর প্রকাশ সিনহার সাথে আমি কথা বলে নিব কমিটি অপথলমোলজি
রাজেশ সিনহা।
হ্যাঁ।
ওকে, হ্যাঁ, কথা বলে নিও। ওই যে ভাটের সাথে যেমন ওই যে নাদিম ভাট একটা দেখলাম, আমি দেখেছি ওদের ফ্লায়ারটা। আমরা ওরকম একটা ফ্লায়ার করব এবং ওরা কি চায় ওটা জিজ্ঞেস করো, করে আমরা কমিউনিটি অপথলমোলজির ওইটা করে ফেলবো। আর শকত আমাদের ওই যে 13 তারিখের ওই প্রোগ্রামটা তুমি রেডি করে ফেলো।
আমাদের ডিপার্টমেন্টের,
হ্যাঁ, ডিপার্টমেন্টের যেটা, হ্যাঁ,
স্যার।
ওটা আমি শিশকেও বলছি, তোমরা দুজনে করে ফেলো। যদি মইনুল না পারে দেন আই উইল প্রেজেন্ট। হ্যাঁ,
ওকে স্যার, থ্যাংক ইউ স্যার।
মোস্তফার সাথে কথা হয়েছে আজকে? না,
হ্যাঁ,
I can
কথা
call
হয়েছে।
you.
And
কথা
স্যার
হয়েছে
আপনি
তোমার?
একটু কল, না স্যার আপনি একটু কল করবেন স্যার।
আমি কল করছি।
জি।
আচ্ছা, ইসে নোমান,
হুম।
আমাদের আজকে মূল প্রবন্ধ কে কে করবে?
Good evening, sir. Professor Sharfil,
Yes.
Good
sir.
evening, sir.
Yes, good
Yes, sir.
evening.
How are you, sir?
Yes, I'm fine. We are together in AIOS in a Phaco
many
in difficult
times.
situation. Yeah, many times.
Absolutely.
Many
Absolutely.
times.
Yeah, now I wanted to come to Bangladesh, but because of COVID, we are not able to
Aha.
come. Yeah.
Hope soon COVID will be off and then he will come
Yes, sir. Yes,
to
sir. Yes, sir.
our country.
Yes, sir.
We welcome you always.
Thank you very much, sir. How's the situation in Bangladesh, sir? How's the...
Now probably we are a little bit behind
Improved.
India because our cases are not much more.
Oh, wow.
And the
Declining,
death
it's
rate
declining.
declining,
What is
and
the-
death rate is
what
not
is the reason
more
because
than
of...
40, 45, not more than that. Yes.
Hi, Suvan.
Hello,
Hi.
hello Shubin.
Hi, Shams.
How are you?
Joven,
First
Hi,
class.
sir.
Absolutely good.
fine.
Suvan.
Thank
See
you.
everybody. Hi,
Great
Iman.
to see you.
Hi, sir.
Hi,
Shail.
Shail. Hi, Shaukat sir.
Shail.
Yes.
Yes,
How's
sir.
that?
Atul
Hi,
Sahib,
sir.
কেমন আছেন?
All fine, Shail?
Yes,
Hello.
sir. All well. All well.
Very good.
All well.
Sir,
Well,
what
how come in Bangladesh it is less COVID cases?
yes, in Bangladesh, sir, actually, in our country, the death
Join
is
Korso?
not very much, but the affection is more. But now it is quite controlled in different situation, and you know the test is very low. The problem is actually we don't know what is the actual situation, but people doesn't want to go for the test, and people are very much reluctant. So actually, the
Reluctant.
actual situation we don't know.
But we can at least predict
Predict.
two
Yes.
things. One, that everyone have already attacked and all have cross antibody. Number
Yes.
one. And number two, there may be another thing that we all have to take our BCG vaccine, each and every one. And this
BCG?
BCG vaccine, yes, that can also help us in our country. And
What
another,
about MMR, sir? MMR also, some people are taking here.
Yes, yes.
They
Yes.
say it is
MMR,
not
yes.
effective.
yes.
And the regular flu vaccine also.
And
Regular flu
in
vaccine.
our country, most of the whole year, everyone has a little bit of flu, and all flus may have some antibody. And that's why probably in our country, we are not moving up, but hope it should be continued. But if it increases, then a lot of people will die if there is any second wave in our country.
If you
We are
want
still afraid of.
sir, if you want some cases in Bangladesh, we can send it across from Chennai.
Okay, we will take it from you later on.
We are the nearest neighbors, so we can do that.
Yes,
Calcutta is
sure,
there.
sure.
Yeah. We will first import to Calcutta, and then
Yes,
from
sir.
Calcutta they can go to Dhaka.
Yes, sure.
Yes, sir.
Sure.
Professor Mohan, you are in the same session, you know, in the airports conference.
Yes,
I
sir,
was
I
with
know,
you.
sir. I know. What a lovely presentation you made. It's lovely.
Thank you, sir.
It was a very
We
good
want to
session.
try your test your presentation in case if it's working. Share and test.
Do you want to share your presentation, anybody?
Now, shall I do it?
I
Shall I
can
do it?
just-
Shall I do
Yes,
it?
yes.
I already checked mine. Yeah.
Okay, I'll check
I'll
mine.
just check
Can I
mine.
share?
Yes.
Suvan,
I'll just
shall I
share.
check mine? Suvan is doing it?
Yeah, I'll do it.
Okay.
Is it on?
Yes, fine.
Is it on? Yeah.
Yeah,
Yes.
it's visible.
Okay,
Fine.
so it's moving.
Visible.
Let me just see if
Just check your surgery. Do you have any surgery?
yeah, I have some videos.
Yeah,
My
yeah.
slides
Hello,
playing?
hello,
slides-
Professor Anju.
Probably all the videos should be checked.
Are the slides playing?
Yes, sir.
Yes.
Slides is
Go to the video.
Fine. Video, okay. Is this video moving?
Yes,
Yes,
sir.
fine.
Yeah.
Fine, then
Yeah.
it's good. Good. So I'll stop
Okay.
share and the next can come in.
Shall I do it, Ma? Suvan?
Yes.
Yes. I've stopped
Yeah.
share.
able to see?
Yes,
That's
fine.
fine, sir.
Yes.
Okay, sir.
Very good.
আসিফ সাহেব, আপনি ফেসবুক লাইভে যাওয়ার আগে আমাকে একটু বলবেন।
Anjum has already joined. Mustafa has already joined.
ওয়েলকাম প্রফেসর আঞ্জুম।
Welcome. Professor Anisur Rahman, Professor Mustafa, Ghulam Mustafa, all have
স্যার আপনি
joined.
কি ফোন করেছেন?
Ha. Mustafa is joining.
Anjum bhai,
Sir,
Assalamualaikum.
very good
আসসালামু
evening.
আলাইকুম আঞ্জুম ভাই।
Yeah. আঞ্জুম তোমাকে ওই যে ইয়ের ব্যাপারে কিছু বলেছে চন্দ্র?
কি ব্যাপার স্যার?
7 তারিখে কোনো প্রোগ্রামের ব্যাপারে কিছু বলছিল?
না স্যার, চন্দ্র বলেন তো স্যার, কথা
ও আচ্ছা, দেখি। তুমি তাহলে আমাদের সাথে 13 তারিখে জয়েন করো। 13 তারিখে একটা প্রোগ্রাম আছে, হাউ টু রাইট এ প্রোটোকল। এটা তুমি আমাদের সাথে প্রেজেন্ট করো আগামী 13 তারিখ রাত 8টায়। হ্যাঁ, তুমি একটু রেডি করে রেখো।
Sir, what background is that, sir? You are having, Sharfuddin, sir?
Yes.
What background you are having?
My background is Bangladesh. It is Bandarban, another hill tracts in Bangladesh. And
Beautiful, sir.
yes, it is not like Japan. Sometimes I saw that many of the people are giving the scenario of Japan, but this is
Yeah.
Bangladesh.
Is
You can visit here.
Yes, sir.
And
Is
this
it, sir,
background,
is it Nilgiri, sir?
yes, Nilgiri. It is Nilgiri.
Nilgiri.
হ্যালো, হ্যাঁ আসিফ সাহেব, হ্যাঁ লাইভে দিয়ে দেন।
How far from Dhaka, sir, that place?
It takes 8 hours probably from Dhaka to that area.
Near
Isn't it?
But
Chittagong. No.
Chittagong and
from-
then hill tracts.
Beyond Chittagong.
Nilgiri, it will take another 2 to 3 hours from
Yes.
Chittagong. Noman?
স্যার, we will start after 5 minutes.
5 minutes. Yes, it is
Sir.
8:05. We will start at 8:10. And
Yes.
we hope that everyone will finish in time, and that's why it will not exceed 10 o'clock, isn't it?
Okay.
Yes, sir. How much time for each talk, sir?
10 to 12 minutes.
10 to 12 minutes.
Because I asked Professor Mahipal, he
Yes.
needs 12 minutes.
Okay.
Okay.
He told him, so
10
you
to
can
12
use 12 minutes. 10 to 12 minutes.
How many speakers is there, Noman?
Four.
Four
Four
speakers.
speakers.
Only four
Four
speakers.
speakers.
Yes.
Yes,
4
sir.
speakers, then discussion, panel discussion, and then conclusion. Debashish Bhattacharya is also joining us. Okay, fine.
Very nice.
Professor Narmata and Professor Sachdev will come shortly because they have another webinar with the JICE webinar with AIS. Hello, sir.
Okay, দাদা।
হ্যালো,
আদাব।
কেমন আছেন?
দেবাশিস দা ভালো আছেন?
ভালো আছে।
Devashik Dada, good evening.
গুড ইভিনিং।
Probably 2021 we will meet you in Calcutta if everything goes well.
Yes, definitely. We are trying to, but don't know. And all
We don't know. Yes.
And we are missing collaborate also because this time it will be probably it will be in
Virtual platform.
Virtual.
Yes.
3rd October.
Yes. Probably on that day we will also meet each other on 3rd October.
You're also there, sir,
Yes.
with us.
So, Shail, how are you?
All well, sir. All well. All well. We
Nice
were
to
just
see you
discussing before you came that otherwise we would have all met in Calcutta in February, but it seems that it won't be possible.
Cross your fingers. Cross your fingers.
Still we have to hope.
Yeah, of course we have to.
Yeah.
No, but
how's the opening up in Calcutta this month?
maybe May or June we'll have the conference there in Calcutta.
Yes.
When are you likely to have, Shivan?
Yes.
Mahipal is there.
Good evening, Mahipal Sachdev. Good
The
evening.
president,
Yes.
the president is there. He can tell better.
Yeah. Thank you
Can
very much
go
for joining.
Good evening,
Thank you.
Mahipal.
My pleasure.
You will be continued with us, or you
Hello.
will just after your talk you will leave?
Hello.
No, I will have to leave, but I'll come back
কথা বলা
again
যাবে না
after my
পরে,
talk.
হ্যাঁ?
Okay,
Dr.
okay,
Mohammed।
fine.
Okay, thank you,
পরে
sir.
কথা
Thank
বলবো।
you, sir. Fine.
ঘন্টা
Okay,
পরে।
thank you. We will start with your talk probably. Noman,
হ্যাঁ, স্যার।
Noman,
হ্যাঁ, স্যার।
first of
Shall
all,
we start?
Mahipal ji, good evening.
Good
Yes.
evening.
Good evening, sir.
evening.
Mahipal, sir.
Good evening.
Good evening.
Debashish, sir.
Good evening, Mahbub sir.
Good evening. Good evening,
Debashish, good
everyone.
evening, sir.
Hi.
yes,
Sir, I think we can start because
Yes.
sir has some other webinars,
okay,
and Professor Namrata has also some webinars. They will, the Professor Namrata
We
will
will
join
have to.
later.
Yeah,
Yes.
we'll
Yes,
interchange. The moment I go, she will come back.
Okay.
She'll
Okay,
come and
fine.
join you.
Okay, sir.
okay, okay. They don't make anywhere blank or vacant. Yes, fine.
No,
Thank you.
No, we have to honor
The-
our
the
commitments.
president and secretary are like Rohit Sharma and Virat Kohli.
Yes, sure,
The
sure. Very
the
good.
bat round this thing.
Yeah,
360
both can't
degree coverage.
leave the crease at the same time.
Mohan, the only thing is that Virat made some progress during the COVID. He made
Yes.
I know.
Academic and
I know what
scientific
progress.
progress have a lot of progress.
Best progress, I will tell you. That's the best progress.
Anji Devashish ji, how are you?
Noman,
Yes.
then we can start.
Okay.
You all agree? We can start now?
Yes, sir.
Okay.
Okay.
Yes, sir.
Thank you, sir.
Okay, Noman,
So I'm-
start moderation. Aristo, you ask them to continue.
হুম।
Okay.
হ্যাঁ, লাইভ শুরু হয়েছে না? Slide is visible?
Yes,
Am I audible?
Yes, yes.
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 Everything okay, Noman?
Mans?
Honorable Chairman of this session, respected panelists and respected speakers, welcome to this session, Phacoemulsification, Overcoming Fear. Actually, this is our first P-flyer, where you can see in this picture, we have just mentioned it to avoid fear during fecal surgery. No fear, enjoy like doing barbecue by manually. That was our P-flyer. And this is our flyer before this webinar, what we have already published. We just made it colorful. Feel the color within the phaco surgery. And in the right corner above, there is a hypermature cataract. So it's the moon in the darkness. We have to think it. Cataract can be done in each and every cataract, all types of cataract. It is not dark, but we have to think like a moon in the darkness. Thank you, everybody. Welcome to the session. This is my great pleasure to introduce in front of you our chairman of this session, Professor Dr. Mohammed Sharfuddin Ahmed. He is professor and chairman, Department of Community Ophthalmology, Bangabandhu Sheikh Mujib Medical University. He is also president of Ophthalmological Society of Bangladesh. He is the president, Bangladesh Community Ophthalmological Society. He is the president, Oculoplastic Society of Bangladesh. He was the first secretary of Bangladesh Medical Association, and he is also the president of Bangladesh Ophthalmic Research Forum. It's my pleasure to introduce my younger brother as a co-chair, Dr. Mohammed Shaukat Kabir. He is associate professor, Bangabandhu Sheikh Mujib Medical University. He is the Secretary General, Bangladesh Society of Cataract and Refractive Surgeons. He is also Joint Secretary General, Ophthalmological Society of Bangladesh. It's my pleasure to introduce Professor Dr. Namrata Sharma as a panelist. He is Professor of Ophthalmology, All India Institute of Medical Science, New Delhi. He is also Honorary General Secretary, All India Ophthalmological Society. He is the Regional Secretary, Asia Pacific Academy of Ophthalmology. He has been awarded with different awards like Senior Achievement Awards, American Academy of Ophthalmology, and International Ophthalmology Education Award, Best Video Award of ESCRS, RANSCO, and Best of Show Awards 6 times by the American Academy of Ophthalmology. We are really proud of her. She has also achieved APAO Leadership Award and Achievement Award from APAO too. Our teacher, our panelist, Professor Dr. Ghulam Mustafa. He is the line director, National Eye Care, Bangladesh, and he is the director, come professor, National Institute of Ophthalmology and Hospital. It's my pleasure and honor to introduce Dr. Devashish Bhattacharya as a panelist. He was the past president of All India Ophthalmological Society, founder, chairman, and managing director, Disha Eye Hospital, Barakpur, West Bengal. The past editor, Proceedings, All India Ophthalmological Society, was the past chairman, Ethics Committee, All India Ophthalmological Society. The president, he got the President Award from Bangladesh, Professor Mahendra Mishra Oration. This is our great honor, and also he achieved the Daljit Singh Gold Medal. It's my pleasure to introduce Professor Dr. Muhammad Anisur Rahman Anjum as a panelist. He is a very good phaco and contact lens specialist, professor and head of the department of our largest medical college in Bangladesh, Dhaka Medical College and Hospital. He is the author of 2 books, Book Review in Ophthalmology, Objective Structure, OSPI Examination, and Introduction to Research Methodology and Biostatistics. I am very delighted to introduce in front of you as a speaker, Professor Mahipal Sachdev. He is Padma Shri awardee, chairman, medical director of Center for Sight, president, All India Ophthalmological Society. He was the past chairman, scientific committee, All India Ophthalmological Society. He got a lot of awards. Kishan Award from USA, S.C. Agarwal Memorial Trophy, Colonel Rangachari Certificate, Krishna Sohan Singh Trophy, Dr. Ishwar Chandra Silver Jubilee Award. It's my pleasure to introduce Professor Dr. Mohan Rajan as a speaker. He was the chairman and medical director, Rajan Eye Care Hospital, Chennai, India. He was the president-elect, Tamil Nadu Ophthalmic Association. He is the visiting professor of ophthalmology, Savita Medical College. Past president, Intraocular Implant and Refractive Society of India. He is the secretary, Shankar Natralaya Alumni Association. He is the member, managing council and scientific committee, All India Ophthalmological Society. Innovator of puncture axis and Rajan Chopper in phaco surgery. And he was awarded with different awards, video awards from American Academy of Ophthalmology, Asia Pacific Association of Cataract and Refractive Surgery, ASCRS, ESCRS, APAO, World Ophthalmic Congress. And the most important thing is the champion of the champion of Ophthalmic Premier League. He won almost 55 Ophthalmic Premier League. I think this is a world record. And I'm really delighted to introduce in front of you Dr. Shail Vasavada, my friend. Is the cataract and refractive consultant, Raghudeep Eye Hospital, India. He has a very good interest on innovations and of new and advanced technology of cataract surgery. He won the Best Paper Award from the ASCRS, Best Video Award from the ASCRS. Dr. Shuven Bhattacharya as a speaker. Welcome to the session. Is the director, Nayan Eye Center, Kolkata, director, Med Events Devices, former fellow Dr. Nagpal's Retina Foundation and Eye Hospital. And he got a lot of awards, AIS P. Shiva Reddy Award, Colonel Rangachari Award, Santi Vision Award, International Hero Award from AIS. And he also got ASCRS Best Paper Award and APCRS Video Awards. This is Dr. Shams Naman. I am Senior Consultant, Head of Glaucoma, Chittagong Eye Information and Training Complex. I am the Member Secretary, Bangladesh Ophthalmic Research Forum. I am General Secretary, Ophthalmological Society of Bangladesh, Chittagong, and I am Council Member of SARC Academy of Ophthalmology. Thank you so much. So we can start our presentation. So first, I am requesting Dr. Shail Vasavada to start his presentation. What are the common mistakes over phaco, how can we overcome? And this is a very basic presentation. I'm requesting him to start his presentation. Dr. Shail Vasavada.
Thank you so much for this kind invitation, and it's a pleasure to be part of this wonderful webinar. I'll be sharing several of the mistakes or learning points that I've encountered in my very short journey so far. So this is a 64-year-old male, retired, scheduled for right eye cataract, has pseudo exfoliation in both eyes, therefore not the most dilating pupil. And having been fresh from residency, having attended many conferences, and having seen stalwarts say that you can get away in small pupils if you follow your principles without using retractors or pupil expansions, I decided that yes, I will follow those principles and I'll use the pupil as my guide for the size of the rexes. And when I turn around, I get a little overconfident, and I've heard people say that you can even go under the pupil because it's a small pupil. And now I start to get a little nervous and jittery because I can't actually see where the flap is. So the next thing that I do is very logical: use the forceps, and the principles to follow is to bring the forceps, pull it centripetally and up towards the endothelium. But while I'm trying to do that, I'm finding that I'm not able to pull it in yet, which means now I'm getting nervous, and I think somewhere here the tear has extended. So the next best thing to do when the tear is extended is to try and join it from the opposite side rather than pulling it from this side. So I went ahead and created a nick away from where the extension has occurred. And from here, I'll try and convert this to the area until which is extended, again injecting a heavier cohesive viscoelastic. And I thought I sort of did reasonably well in making sure that at least one part has a very strong capsulorhexis margin, but something still didn't seem right. And finally, I thought there is some flap, some tag here and there lying. And finally, I decided that it's probably better if I actually see what's going on below the iris. And on putting the iris retractors, notice here that the rex is actually never extended. It's here, if you see the flap, it's a tongue shaped flap which can easily be held and be converted into a complete capsulorhexis. So I think this is the first most important lesson. If you notice here, there is absolutely no extension. It's just extending just below up to the iris, and it was easily converted into a normal capsulorhexis. So always do rexes under visualization, and you can put in iris retractors even in between if you have not put them right from the beginning. So don't hesitate and make it as an ego issue. The second learning point as far as capsulorhexis goes is that this case which appears a fairly good glow, well dilated pupil, and you feel okay, now you are experienced, so you should be able to do without doing trypan. I would suggest trypan early on for all cases, but once you start feeling experience, you start reducing the use of trypan. And here, I'm struggling. I don't know whether the nick has been created properly or not. So I'm using a one-tooth forceps to try and rotate the globe in different directions so that I can get a better glow. And I'm still not sure whether actually the nick has been initiated, or is it just a partial tear, or what's going on. So I'm struggling to push, I'm struggling to see whether the flap is everted or not, whether I'm seeing well or not. The patient now starts getting a little bit uncooperative. And finally, I decide that I need to see what's going on. So I inject a little bit of BSS below the viscoelastic and go ahead with trypan staining under the layer of BSS, because remember, there is already a OVD or viscoelastic inside the eye. And once that is done, now you'll notice, once the trypan gets washed out with the viscoelastic and water, that now it's much easier to see what was happening, and now it's much easier to go ahead and complete the capsulorhexis. So I think the important lesson again here to learn is that you are never too experience to not use capsule staining whenever in doubt. And this particularly occurs in cases where apparently the glow is very good, but they have a very dense posterior subcapsular or a dense cortical cataract, and only in that particular quadrant you find difficulty and you may end up in trouble. And capsule staining can also be done midway through the capsulorhexis, even if you have not started it right from the beginning. Coming to another case of a 68-year-old gentleman scheduled for a second eye toric IOL, a Brunison cataract. So we do expect a difficulty in chopping, and in such cases, try and make a slightly larger rexis. So notice here, I'm trying to attempt a horizontal chop where you go ahead with the chopper behind the equator, and horizontal chop is extremely efficient, much more efficient than vertical chop, particularly in a Brunison cataract. But the disadvantage, of course, being that you are sometimes going blindly below the iris or below on the capsular rexis margin. Once again, coming from the equator towards the center and still struggling to crack this nucleus. Finally, we could do that, and things seems to be going off quite well. We've been able to remove the fragments as well. And irrigation aspiration bimanual is my preferred technique for cortex removal. And while doing that, I start noticing some fluttering going on here. And on removing this cortex, it's now clear that there is the capsular axis is not completely gone to the equator, but there is a tear here. If you can notice here, there is a tear, and this flap has fortunately not gone up to the periphery or the equator, but there is a flap that is there. So the next important thing to do is to try and convert this, and this is the time when I would suggest that even if you have used methyl cellulose for the entire case, use a heavy cohesive viscoelastic, and it's important to know where to inject. So if I go and inject cohesive viscoelastic in this area, it's more than likely that it may actually extend the flap of the capsular rexis here. So inject it in the area where you are going to actually convert this tear. And then with the help of these micro incision capsular rexis forceps, try and bring the flap centrally, that is centripetally, and pull the forceps up towards the endothelium so that you can restrict the size. And once this is done, now this is like just a slightly larger complete capsular rexis, and you can go ahead with in the bag implantation without any fear, because that was very important in this case of a toric IOL. So be aware of the rexis margin in the area of phacoemulsification, and this occurs very commonly in the beginning phases. Either this occurs when you are attempting chop and you inadvertently go above the capsular rexis, and therefore for beginners, I think vertical chop is a much safer option because you are working within the capsular rexis margin. And the second way this can occur is particularly with the torsional ultrasound. If you go very close to the capsular rexis margin, you can cause a split in the anterior capsule. But it's important to convert it into a strong margin at any stage before proceeding further with appropriate use of viscoelastic. The third, again, a seemingly very innocuous cataract, soft cataract, nothing very much, just a central posterior subcapsular cataract. And for soft cataracts, 4-quadrant is our technique of choice, and we managed to do that well. We are removing the last fragment here. It's a slightly smallish rexus, but everything is gone off quite smoothly. The lens removal has been done. And notice here, once we come to cortex removal, I'm finding a little bit of difficulty in removing the cortex. And keep noticing this area. When I'm trying to remove this cortex, oops, the entire capsular bag with the fornix is actually detached here. So while I'm trying to pull the cortex, the bag is also coming. So the first thing that you want to do is not to continue pulling. So the first thing that you want to do is to press reflux on your foot pedal so that this is gone. And the second most important thing is to try and now stabilize this bag. Capsular tension ring is of great help, and it's important that you make sure that the leading haptic goes in the capsular bag. Here, while I was very conscious of the dialysis and whether I'll be able to save this or not, it didn't occur to me that this has come off the leading eyelet and has gone actually in the sulcus. Fortunately, before I placed in the trailing haptic, I realized that, and I could manage to pull it out from the sulcus. But once you actually dial this in, and if it goes in the sulcus, it's impossible to actually find it out. So the easiest trick is to actually thread this eyelet, if you notice here, with a 10-0 nylon suture. So what that does is that even in any inadvertent situation where you are not sure and you want to pull out the CTR, you can use this suture to actually pull out the CTR. So this is a useful trick, particularly in your first few cases of CTR, when you are still trying to find the ergonomics of how to dial, how to place both the eyelets in the back, and so on and so forth. And then, of course, once the CTR was in place, because this was not a very large dialysis, rest of the surgery went off well, and the patient is doing well post-operatively. So we went ahead and saw the video and tried to find out why and how did this dialysis occur, and there was nothing, no obvious sign on the slit lamp. And on reviewing the video, it was found that the hydrodissection was probably inadequate. And notice here, the forceful rotation with the spatula, and I'm just rubbing it in and making sure that all the possible zonules that are there get broken. So the first important lesson to learn here is that if it doesn't rotate, rehydro it. Don't overstress it. And this is something we faced early on in our femto cases, where we were skeptical in doing aggressive hydrodissection. But if it doesn't rotate, come out, rehydro, and then make sure that the nucleus rotates before going further or before making any stressful maneuvers. So the first important lesson: rehydro, and avoid forceful rotation. And if the rotation isn't smooth at any point of time, you must always come out and always rehydro. The second important lesson to learn is that whenever there is a zonular dialysis, never withdraw your irrigation completely. So maintain a low irrigation, reduce your bottle height, and inject a dispersive viscoelastic over the area of zonular dialysis, because that will actually stay there and allow it from progressing further. And the third important lesson is that, particularly in the early on cases, always thread the CTR prior to inserting in the AC. You will have an easier way of removing it. Another case of a 68-year-old female, heavy breather, a normal pupil, smallish rexes, and notice a little bit of overzealous hydrodissection. So the aim of hydrodissection, if you see a good wave, you don't need to do it further. So a couple of good waves have already been seen. But still, the surgeon feels that it's probably still a better idea to do more hydrodissection because of the cortical cataract. And notice here, while entering the cannula, there will be a touch to the iris. Now, this small touch to the iris itself can be enough to trigger iris problems. And again, 2-3 times hydrodissection was done. And notice this: the pupil, the iris has started coming towards the main incision. The second thing that most of us do reflexively is to inject more cohesive viscoelastic, and this will make matters worse. This will push it even further with more viscoelastic in the center, and then you are stuck with these maneuvers of using metal instruments to try and swipe it and put it into place. But because there is excessive viscoelastic actually inside the eye, when I'm trying to again push the phaco probe in, the iris is still tends to come out. The next mistake that I do here is to inject again more viscoelastic from the same incision. And you should never do that, because it will constantly keep coming out. So now this side is coming out. So now finally sense prevails, and we go from the opposite side, and you inject dispersive viscoelastic over this area, because that will help to make sure that the iris stays there. And then we reduce the bottle height, the IOP in this case, to the lowest possible, so that the fluidics are maintained right in the center. And what could have been a disaster of constant iris prolapse coming right through the surgery could be avoided with any further iris prolapse right through the cataract surgery. So important lesson, that whenever again the iris starts coming to the main incision, go from the other end or from the other side port. Do not swipe the iris in, but just inject dispersive viscoelastic from away, and the iris will fall back into its position. And this can be at any stage of cataract surgery. This in a case before starting irrigation aspiration of the cortex, go from the side port and inject dispersive viscoelastic, and the iris will come in and fall back. So avoid excessive hydrodissection, dispersive viscoelastic from the opposite incision in low parameters after starting that. A small pupil with toric posterior subcapsular only, and with this pupil and the soft cataract, we felt it's no big deal to consider cataract surgery without retractors. So I initially made a side port and thought, let me put retractors, but then I changed my plan that this pupil is dilating enough with viscoelastics. And coming to cortex removal, sometimes whenever there is a thick epinuclear plate and you don't catch the anterior cortex and you actually try and grab the epinuclear plate, what often happens is that the anterior cortex breaks off. And once the anterior cortex breaks off, it's impossible to actually grab anything like has occurred here. So now there is a plate remaining with no anterior cortex left. And so I'm struggling from right hand, left hand, polish mode, high vacuum, low vacuum, high flow rate, low flow rate, but I'm just not able to catch anything because there is no anterior cortex left to catch. Finally, some sense prevailed, and ego put aside. We dilated that part of the pupil, and then we could actually go vertically engage the plate of the cortex and remove. And notice this white stuff here, that is nothing but corticocapsular adhesions, which means they are firmly adherent to the fornices. So retractors, whenever in doubt, and cortex removal needs to be done in a stepwise manner. The acronym POPs, this is now in publication in IJO next month. Uh, First is to position the aspiration probe just below the anterior cortex and never the posterior cortex. Occlude it with low vacuum. So even if my vacuum preset is 300, the vacuum goes up only till 130. Then posteriorly detach it. If you keep looking at this animation, you actually pull it down, and then you actually make swiping movements so that there is absolutely no radial stress on the zonules, and it would also help in more equatorial lens removal. And then only when the cortex come to the center do you foot press maximum on your foot pedal. And during conventional radial pull, this is a courtesy to my colleague Dr. Samresh Srivastav for this animation. Sometimes what happens is that this is the fornix, and when you pull it radially, it breaks off, leaving behind a plate and lots of epithelial cells in the fornices, which lead to PCO. And compare that, if you do it with a step-by-step technique, there are lesser chances of that happening and more chances of complete removal of the cortex and the lens epithelial cells. So I think I'd like to end at this point of time, and I can all go on for hours and hours with the number of complications that I've created over the period of time. But thank you so much for the patient listening.
Beautiful.
Thank you. Noman?
Yes.
Noman?
Thank you.
Yeah, our
thank-
next speaker will be Mohipal Shasdev, as
Yes,
he's
yes.
so busy.
So
Okay.
we will discuss on this
Later on.
matter later on. First, I'm requesting Professor Mohipal Sachdev to finish his presentation. Professor Dr. Mohipal Sachdev, the time is yours.
Thank you very much. Good evening, Professor Sarfuddin Ahmad, Dr. Noman, Debashish, Shal, Mohan, Suven, Dr. Kabir. It's a pleasure being here with the Bangladesh Ophthalmic Research Forum, and I'll be talking about the third hand. Which I'm going to talk about is essentially how do you make use of the pars plana approach to get good outcomes for difficult cases. Is everything visible?
Yes, sir.
Yes. Yes.
Okay, so I'll be talking about how my posterior segment surgeons cooperate with the anterior segment surgeons, and as to how we get great outcomes. So let me just show you this first, starting the video.
23 gauge micro incision trocar cannula system
Is the
forms
volume
the
all
backbone
right?
of this instruction
Yes,
course.
Sir.
It is
Yes, my God.
imperative to understand its component and usage to fully utilize the tricks shown in the subsequent videos.
So this is
A
the
typical
trocar cannula
normal
set.
trocar cannula set consists of 23 gauge trocar cannulas,
23 gauge
an
trocar,
infusion pipe, and 3 scleral plugs.
scleral plugs, and the pipe.
Trocar cannula consists of a sharp spear-shaped trocar.
So this
threaded
is sharp.
over which is a round-bodied cannula.
So this is the cannula, the trocar.
In a phacoemulsification, the cannulas are inserted 4 millimeters from the limbus. The conjunctiva is retracted slightly, and the trocar cannula is inserted in a two-step fashion.
It's a two-step
initially
fashion,
going parallel to the
parallel,
limbus for
and then
half
going
its
in.
length, and then going perpendicular to enter the sclera. The infusion is secured in the infratemporal cannula. And the superior ports used for the vitrectomy cutter are plugged till further use.
This is the second port. You
It is a
may or may
relatively
not
simple
need it,
technique which
but
can be
you,
mastered easily with little practice.
yeah. So let's see how we utilize this particular technique for different difficult cases. So this is as you all know, that whenever there is a case which is a hypermature cataract, an intumescent cataract, you can do staining, you can do mini capsular X's, you can do Mohon is here, you can do puncture X's, etc. But despite doing all these, there could be the problem of high intralenticular pressure. And the moment you enter, you can see here, you're just trying to extend, and this is a radialization of the tear, and you get what is known as the Argentinian flag sign. Plus, in case you have a high pressure, you have the possibility of having an expulsive hemorrhage, which again could be a problem. So this is again a difficult situation. You can use a femtolaser assisted cataract surgery in hypermature cataract, intumescent cataracts to get a good capsular access. But then the issue is not everybody has this. Now I'm showing you this case of an old lady, 86-year-old, hypertensive, CAD, diabetic, thyroid, etc. Not getting controlled on the pressure despite mannitol, topical anti-glaucoma, etc. And we have to do her cataract. She is being taken up with the help of the posterior segment surgeon, and you can see that we are using the same technique that I showed you at the beginning, that is the trocar cannula. Once you have this, you please see this, that we are not entering anywhere inside. You can see that whatever fluid is coming out as also the part of the liquefied vitreous that is there, we just taking it out with the vitrectomy cutter, just aspirating it out, and you can cut it. So you really don't know. And just by doing this, you can see that the pressure of the eye has fallen down. So we don't want to do a blind vitrectomy behind a hypermature cataract because we don't know, we might injure the lens. But you can just see that how we have been able to reduce the pressure of the eye. And this lady who had a very high pressure, intraocular pressure, because of the phacoemulsification glaucoma, we are starting with trypan blue, and you can see that we start with a small capsular axis, and you can go ahead and then increase the size of the capsular axis, because now the capsular axis is under control. So you can see that now after having made a small capsular axis without any extension of the tear, because we have been able to reduce the pressure from behind, that is from the vitreous. So you can see that we got a good capsular axis. Now the basic phaco procedure, because the cataract was reasonably of a medium category, you can go ahead and finish the phaco procedure with reasonable ease. And anytime you feel that the pressure is high or low, you can work on it. You don't want the pressure to be too low. You don't want corneal folds to come in. So therefore, you are looking at touching the globe, and just see here, the pressure has suddenly become high because of some fluid going back, and you can see that this is the iris which is coming out in part, and you can see that the globe is tight. Now, what do we do at this particular time when we are in the middle of the procedure? Because you have the cannula in there, you just take out the plug, and you can see that just again by removing some fluid and whatever is coming out without actually going into the vitreous, you can see that we are able to soften the globe. So you can see that the globe has softened, and in this particular case, we can go ahead and finish the irrigation aspiration, which is very easy because you are not working against a high pressure. And this, you can see that an intraocular lens also goes in very gently into the capsular bag without any problem. So this is really the one of the ways that I have showed you. This is the cutter being used to do a peripheral iridectomy, because a case of chronic angle closure glaucoma. So we are just doing a peripheral iridectomy. Just remove the cannula, as you can see. And because the patient was a chronic cougher and old lady, we just put one suture, and you can see is the post-op day 1. So this is one of the cases where I have shown. So let us go on to the next case. In this particular case, again, what we are saying is that we will meet the challenge head on, and we will not give up, because we have the help of the posterior segment surgeon there. Now, this is a case of a traumatic cataract. You can see that there's a linear tear. And the moment we are doing an aspiration in this young person, you can see that there is a huge posterior capsular rent that is appearing. And Dr. Vijayawada and group has, you can go and if you put a lot of fluid from the interior, you can see that the fluid will only bring up the vitreous more into the interior chamber. And here again, you are following a posterior approach. So when you are following a posterior approach, you can go behind with the vitrectomy cutter. You can use it as a cutter. You can use it as an aspiration. So you, as on the foot switch, as it was shown here, that position 1 and 2 vitrector, whether you want or you want the aspiration, and third you get the vitrector. That is up to you as to how you want to do it. But when you switch between the two, if like I am just doing the aspiration at this particular point and not using the cutter for aspiration or cutting the vitreous that is available. But the important thing here is that if you use it from the pars plana approach, you will be able to handle this situation. You can see that's the problem. And in this particular case, now we are going ahead and doing the cutting of the vitreous which was coming through the posterior capsular red. And in this particular case, because there isn't a good capsular axis, we are using a 3-piece intraocular lens. You can support it with the pipe from behind. As you can see, we are supporting in this particular case because the haptic was going in. Available posterior capsule except for the linear tear which was there. So we'll just dial it in and we can leave it at this particular point. We can make it into optic capture also, but that would be better if we had a capsular axis. So I'm not trying that. Otherwise, I would have the linear cut one could have looked at from that point. Now, this is a case of a doctor who came to me from Patna, who had a traumatic subluxated cataract, as you can see in this particular case. And he was referred for the surgery to me. Now, in this particular case, I am using the femtolaser, and you can see that this is a subluxation, the iris falling back here, and you can see a vitreous right here. There is a vitreous which is available, coming out from the area of the subluxation. So you have to do some maneuvering to have the posterior capsule and the anterior capsule come properly. Now, what we are going to do here is that even though the vitreous is there, we will get a good capsulotomy. I'm trying to get a 5mm capsulotomy on the scanned capsule center, but it is cutting on the iris. So I reduce it to 4.5, but even on reducing to 4.5, you saw that it was coming on the iris. So what we will do is that instead of a scanned capsule center, we'll go on to the customized center so that I am able to try and make it as much decentered that once the capsule is pulled back, we are able to get a good centered capsulotomy. So I'm getting it at 4.9mm, the capsulotomy. You can see that this is the subluxation, which you can see. This is the capsulotomy that is happening. And now we are having the nucleotomy that is being done by the femtolaser. Once we have the nucleotomy that is done by the femtolaser, what you have achieved is without disturbing the vitreous, you have got a good capsulotomy. You have also got a good nucleotomy so that the amount of manipulation will be significantly less. So now just to show you that this is, again, we are using the trocar cannula, and we will be using the advantage of the pars plana approach. So again, we are removing whatever vitreous and fluid is there. And because I can have a good visualization, so I am putting the tricot and removing whatever vitreous is here so that the lens does not, as we do the phaco, it should not perpetuate or accentuate the amount of vitreous that is coming. Now you can see here that the capsulotomy has come very well, just being a little careful. And right at the beginning, you can use capsular hooks, but they will not give you a symmetrical round push. So we have put in an endocapsular ring, and you can see that the area of the subluxation has got covered and it has pushed the capsule to the side. And now, because we have already pre-chopped the nucleus with the femtolaser, we are able to remove this nucleus very well without causing any disturbance to the posterior chamber, that is the vitreous, and we are not having any additional vitreous that is coming out. Now you can see that I'll be using a bimanual approach to remove the epinucleus and the cortex, and it is better to do a bimanual approach in these cases. And the endocapsular ring, you have to actually strip the cortex, otherwise it becomes a little difficult with the endocapsular ring in there. Now you can see that this is going layer by layer of the cortex, and we have been able to get a good removal. Don't remove both the hands, keep the infusion in and put viscoelastic and then only, because you don't want a sudden upthrust onto the posterior capsule, and we are putting it a 3-piece lens. This 3-piece lens is going to support the area of the subluxation. And now right at the end, we again go in under direct visualization, see whatever vitreous is there, and we will be doing a vitrectomy to remove the vitreous, so that you can see that the vitreous is still coming into the wound here. The tricot that had been injected clearly shows the stand of the vitreous. So what we are going to do in this particular case is that we will change the direction of the cut that we are having, and we will take out the, we'll have the fluid coming in from behind now, and we are putting in the cutter from the side port and cutting away the vitreous which was coming into the wound. And you can see that there is a good clearance of the vitreous from the wound, and this is the post-operative outcome that we have in this particular case. So you can see that these are a couple of cases that we would wish to show you as to how the pars plana approach is helping us. Now we would also want to show you that when we are looking at the pars plana approach, we can also use a chandelier's endo-illuminator. The chandelier fiber reflects from the retina, retro-illuminated on the lens. You are putting an illumination from the behind. So you can see here, we are putting an illumination from the behind, and again it's the posterior segment, which I call the third hand, who are helping us. And when you put the microscope off, you can see that this good retro illumination hitting the retina and coming back. This is self-retaining, leaves a self-sealing wound, and the design of the chandelier's illuminator is such that it gives you an excellent glow. So you can see this is corneal opacities which are there, huge corneal opacities, and we are planning to do a phacoemulsification in this particular case. So you can see that we are here having the microscope light off, and we are doing the chandelier's illumination, and you can see that we can get an excellent capsulorhexis even in the presence of any corneal opacities. And look at the depth perception that you get. It's an excellent depth perception that you get, and the chopping, etc. Everything becomes so very easy once you are doing a chandelier's endo illuminator assisted phacoemulsification in the presence of corneal opacities. Now you can see that all these steps are very easily visible, as is seen here, and this is the nucleus that is being taken up, and as we go along, this is the epinucleus. Look at the clarity that you are seeing, and this is the irrigation aspiration that we are seeing that is happening in this particular case. And we can go ahead and put in the lens. This is another case that we were showing. This is a case of blast injury where the cornea was studded with small little blasts, and you can see that this is a corneal opacity which was there, which was so very dense that I showed you. And this is, you can see post-operatively after the surgery has been completed. This is another case, as I am showing you, of the gun blast injury, and you should use trypan blue, and you can see that it is such a bright, intense light that you are having, and we are able to take away, and this is the end of the surgery. Mind you, you could never have done it without the help of the chandeliers. And this is a case of repeated failed grafts in which we are trying to do a DSEC, and you can see that the DSEC is showing us excellent good results which are there. Finally, I think I have shown you a couple of cases where we use the also be used with the small pupil irregular shallow AC angle case. So you can see this is a hard cataract, and there is a PI iridotomy that has been done. You can see again that iris atrophy is there. This is iris atrophy there, and you can see on top of that that there is a subluxation which is noted in this particular case. So you can see, can you see clearly in this hard cataract, tamsulosin, angle closure glaucoma, iris atrophy with subluxation? How do we manage to handle this particular case that we are wanting to do? So in this, we will go ahead, we will put a Malugan ring. As you can see, a Malugan ring has been inserted. You can see that there is a subluxation which is clear. You can see that the iris not in the normal configuration. Again, in this particular case, we are using the power of the femto laser. We are doing the maximized pupil diameter, and we are also doing the procedure where we are going to have the making it into 6 quadrants. So you can see that this is the fastest capsulotomy that you get on the Catalyst system. There is no indentation. You don't have any tags which are there, and it's a great system that I am using. And I about 70% of my patients we are doing the femto-assisted cataract surgery who are coming to me for cataract surgery. So you can see that this is now the completion, and after we have completed this particular procedure of the femto, we'll have the patient in the OR. So once you have the patient in the OR, you can see that that is the ring in this particular case. Again, what we will show you is the multiple use of small little devices. You can see that because it is a pre-chopped cataract that we have, we will be able to work around it. You can see that there is stickiness of the nucleus, but as was pointed out by Shal, we are not using too much of strength to kind of rotate the nucleus because it is, as it is, a subluxated and a hard cataract that is there. So you can see that we are going in, and as we go in, we tend to just go in a little deeper. Because it was not rotating, we put some viscoelastic, did some more gentle hydro dissection using two hands gently, and now you can see that once we have used them gently, there is a rotation that is happening. So once the rotation has happened, you are not very comfortable. So it's better to use capsular hooks, but we are using an iris hook to stabilize the capsular bag, you can see. And now we are able to rotate as I showed you, because we had earlier disengaged the nucleus gently, and you can see that the power of the femto, we have already got the cracks which is there, and just going on the double speed actually, and you can see that the nucleus comes out pretty well in this particular case. So where we are working is that we have used the Malugan ring, we have used the femto, we have used the a capsular hook, an iris hook, basically as a capsular hook, and given support to this particular unstable bag. You can see again that we are very cautious when we are trying to remove the epinucleus, and the epinucleus, again, I thought in this particular case there is an additional support that is required, so we go ahead again and give a second support onto the capsule. So you can see that's the capsule that is being supported, and now removing the epinucleus becomes slightly less taxing. So enjoying your phaco, as is the topic of the webinar, in difficult situations, you have to actually use all your strengths and all your maneuvers. So again, you can see bimanual irrigation aspiration, gentle peeling off of the cortex, which is required, no depressurization all of a sudden, having viscoelastic. After putting viscoelastic to stabilize the bag more, there is an endocapsular ring that is being threaded in, and you can see that the endocapsular ring goes in, and once the endocapsular ring has been threaded in, we go in, see that is the endocapsular ring which you are gently putting into the capsular bag, and then we go in with you can go in with a 3-piece lens, or you can go in with a single piece. A 3-piece lens at times is much more preferable, and because that gives an additional support, as I showed you earlier. And you can see that now you can go ahead and remove these additional gadgets that we had used, the capsular support, as also the iris dilator which was there. So these are again just a vitrectomy being used on the inside to see if there is any vitreous that has come in, and just to clean up the whole situation that is there to get a good outcome in this particular case. So friends, this is all that I'll wish to say, that there is what I'll say, you have to use everything in your power. And I think the retina people, the VR people are great people who can come to your rescue. And when we use the third hand, we can manage these tough and difficult cases. Thank you very much for your kind attention.
Thank you, Professor Mahipal Sachdev, for your excellent presentation. We have learned many things from this presentation, and now this is the time of discussion. Actually, I am requesting the panelists to discuss about our two presentations by Dr. Shail Vasavada and Professor Mahipal Sachdev. I am requesting first Dr. Devashish Bhattacharya to tell something about those presentations. Please, Dr. Devashish Bhattacharya, sir.
Excellent presentations from Shail and Maipal. There were a lot of take-home things. Shail, definitely as careful and as meticulous as he is, insisted that we see everything and we shouldn't do things without seeing. He definitely brought out the points that if you have not used a retractor to begin with in a small pupil, at any stage where you are not comfortable, where you don't see, you don't do, and put in a retractor, see and do it. Then suppose you don't see the capsule, so you stain it. This is another learning. Steve was talking the other day on a webinar. I think it was a Bangladesh forum, where actually we have a misconception that if we have given a viscoelastic, we can't stain the capsule any further. But if you keep a BSS interface, you can go below that and stain, which Shell showed very efficiently. And then again, he used the Irish retractors. And of course, the point that he made that you keep 10-0 nylon on the eyelet of CTR when you are threading the CTR in is a very valid point. Of course, Shail is a great proponent, and so am I, of pars plana vitrectomy managements in PCRs. It comes from the Vasavada clan. So, and today Mahipal endorsed it by showing us so many cases. One where there was a high intralenticular pressure. Second, phacoemorphic glaucoma. And I think we had other cases also where he demonstrated. And of course, the last case, I would also want Shell's opinion, but we prefer the anterior irrigation when we are doing vitrectomy, pars plana vitrectomy, because we need not hydrate the vitreous from behind. We can do that from the anterior chamber and do the vitrectomy part from the pars plana. That probably gives us a better coordination. We will want the opinion of the panelists. And the last case, of course, Mahipal did everything that could be possible. It was excellent to see. And of course, the chandelier illuminations in bad corneas, it definitely helps, and you can do wonderful surgeries by using the chandelier illuminations. So a lot of take-home points, and we can critically analyze and discuss every bit of it. But I leave to the wisdom of this learned panel, and let's go forward and discuss them, because they've said a lot of things. So we need to assimilate all of them. Frankly, about the last case that Mahipal did, well, I wouldn't have done femto in that case, honestly, because you have a small pupil and you have a subluxated cataract. He later used the Irish hook, but I think I would straight go away with a small nick in the capsule and stabilize the bag in that part and go ahead with the rexis and go forward. That would, and a pars plana approach to manage the vitreous, which was there in the anterior chamber. So this is a small difference which probably I would think of in the case that he did, but I think Mahipal has his good reasons for the way he managed, but it was an extremely difficult case and the outcomes were good.
Thank you, sir, for your excellent talks. I am requesting Professor Ghulam Mustafa. Are you there, sir? Professor Ghulam Mustafa? Hello, Professor Ghulam Mustafa?
So, Dr. Debashish, just to reply to your thought process regarding the femto, thank you very much for this thing. The issue is that when you have a subluxated cataract, you don't get the counter traction that you want to get, or the traction. Otherwise, you have to actually use 2 micro rexis forceps to do, and getting even the first nick becomes very difficult. And if, like in the other case that I showed you in the doctor from Patna, where there was a huge subluxation and there was vitreous coming, That is the power of femto, that you can get a rhexis without actually increasing the subluxation or without actually bothering that there is a vitreous into the anterior chamber. That is what I wanted to show. That is actually the advantage, that in until of course the subluxation is so acute that the lens is like dangling like this. You will not be able to adjust the femto to that. But if there is a subluxation up to a particular angle because of the 360-degree OCT that you have, you are able to get even in strong tilts, even in reasonable tilts, you are able to get the focus of the capsulotomy laser onto the area of the capsulotomy that you want, and it disregards the presence or absence of vitreous, and it does not cause any sort of turbulence in the anterior chamber or any increase in the subluxation that you can get when you are doing a manual capsular rhexis.
I will also agree with my part.
Yeah, and the second thing, thank you. The second thing is that the nucleotomy reduces the amount of manipulation that you want. The pre-chopped nucleus will reduce that. Yeah, Mohan, sorry.
No, I fully agree with you, because it makes, if you are able to get the rhexis right in subluxated cataract, I think 90% of your battle is won. Because that is the most difficult thing in a subluxated cataract, because you don't have the peripheral resistance when you're doing the rhexis manually. But if you do the femto, as you rightly said, the femto rhexis is bang on target, number one. Number two, your nucleus is also emulsified. Very little manipulation of the nucleus is also necessary, and everything is over in a jiffy. So I think it's I would have gone.
No,
Access to
Maipal,
is the best.
I don't say that, Maipal did, I mean, it was an excellent job. What I just wanted to understand is to, because the pupil was small, you first go in and put in a Malaguin ring and then do the femtorexis. There is a tilt. And so, there are too many things around that, but you have
that's what I was going to say. Enjoy. That's what I wanted to show. Enjoy your surgery. Let the level of difficulty keep on increasing. See, the only problem is that pupil is small, so even if you are wanting to do a rhexis manually, you will want to dilate it. The issue is that you can use Malugan or Bhattacharjee ring, etc., and then go back and do the rhexis with a femto. So that is all that I was trying to show, that these are the feasibilities and the possibilities that are there. And fine, difficult, tough cases, these are tough cases, and only the tough measures will survive in these cases. And that's what I was wanting to show, that you can get. Otherwise, I'm sure that if we had done the normal phaco and things like that, we had tried, we will get a nucleus drop, and then we might have to do glued IOL or things like that. So definitely, yes, that small little application, whether it be the ring, whether it be the retractor, which was used as a capsular hook, whether it is the femto, whether whatever, each thing adds up to the final culmination of getting a good outcome. And one should not be afraid, rather one should have everything handy to actually pivot yourself to getting the ultimate outcome that you are desirous of. And all that I was wanting to say, because I wanted to show this case in this particular symposium, because the challenges are significant, and that is what it is, that you can overcome the challenges and you can enjoy your procedure if you have the proper armamentarium in your hands. So I think it was, I wanted to show you tough cases only. That's what was my presentation.
Thank you. Thank you. I think thank you so much for excellent discussion. And I think this is really a very good points we have discussed. I'm requesting Professor Anisur Rahman Anjum sir. Do you have any comments, or do you have any experience over this?
I have not said enough comment. I have just congratulate Shahil Vasavada for his. So far, we use in case when there is visco, you have to evacuate it, then insert the Blu-rays. Yeah. Otherwise, when there is viscosity is there, Blu-rays can color the capsule.
So that's very true, that it is a little challenging. What you correctly mentioned is that the one option is to try and remove the viscoelastic.
First you remove.
The other option is, like Dr. Debashish sir correctly mentioned, is what Dr. Steve Ashinov described actually as what he calls as his try soft shell technique.
Yeah,
What he describes is that below the actual viscoelastic, you just go with your hydro cannula and just put some just touch your cannula to the capsule and just inject some squirt BSS below that. So what he believes is that that creates a little bit of layer of BSS that you can actually go and inject. But I think washing out the viscoelastic and staining again is absolutely as feasible as that.
Yeah, so patience is a very vital thing. So, I've seen that many of us inside when there is visco, but without vehicle. This is important.
Very good. I agree.
The only problem is shale. I think when you have a flap there and you try to wash out the viscoelastic, there's a possibility that you may pull up the flap so they can extend. So my suggestion is, as you rightly said, just put BSS there and put the visco. That is, put the trypan blue, and that is good enough for you.
What I do is
when there is when this cross virus, do not use the main port. Go for another port.
Okay.
Go
Thank
for
you,
another. Very good learning. We do this, and I think this is for our juniors and those who are learners, and for also for us. But I have seen many of our colleagues or juniors, they used to do surgery when there is cross iris is going on, but still put visco through this main port. But no, this is not it. This is you create a secondary port, then you put visco.
What sir have already mentioned, I think this is really very important. Yes.
This is very regular happen in when there is patient getting a tamsulosin. This is very usually happen. This things are problem. So
Dr. Shuvan, do you want to tell something?
What I was saying is I always use a cannula, which is a separate cannula for trypan blue injection. This is a bent curved cannula which follows the contour of the anterior lens surface, and it's got holes beneath. So that is a very useful cannula which you can use even under viscoelastic to stain the capsule. It just forms that the trypan blue itself forms that layer of fluid over there, and it's directly injected onto the capsule. So you don't really need to take out the viscoelastic.
Yes.
So that is a cannula which I regularly use as such for my trypan blue staining. So that minimizes the wastage of trypan blue and trypan blue coming anteriorly also. So that's all.
Can I ask one question from the audience? Some audience just asked a question. In a subluxated lens, sometimes in each and everywhere the capsular tension hook is not available. Can you use the iris hook to settle the subluxation lens as a capsular tension hook? Can you use the iris hook as a capsular tension hook?
Can use
Mohipal, unmute yourself.
Capsular tension ring is something different from capsular hook. So I think you are asking a question that can we use iris hook instead of capsular hook?
Yes,
not capsular tension ring. Yeah, so you can. That's what I showed you, because often we don't. The only thing is that these the capsular hooks are curved like this, and they do not put the pressure to that extent, and the chances of having a capsular rip is significantly reduced. But in case you are using the iris hooks, you can use them. You can use 1, 2, 3 depending upon what you want to do. But these are supplemental roles. The CTR and the capsular hook or the iris hooks can be used. But when you are using an iris hook, do not pull it too hard. That is the only thing that I wish to tell, that at times you can rip it. But otherwise, we use it pretty often, because capsular hooks are not really very few people are manufacturing it in India. We had only iris hooks which were available from the Indian manufacturers. So you can use them, but just be a little cautious that you're not pulling it too hard. That's it.
Thank you.
Mohipal, I have a question to you.
Yeah,
you have mentioned that there is the Argentinian fluoxetine and also phacomorphic glaucoma. In these cases, how you use this 23 trocar cannula? This type of case.
No. Those were different cases. I just told you that in an intumescent cataract, you can get an Argentinian flag sign. So you are better prepared, and you know that this patient is a phacoemorphic glaucoma, intumescent cataract. So I am pre-prepared, and that is why we used the pars plana approach to decompress the back part so that the upthrust is reduced. So that is, I was just showing that even in the best of situations, you can have an Argentinian flag sign. So to avoid that, we are pre-prepared, and we gave pre-op mannitol, we gave a block, and we gave Diamox, etc. And we went through the pars plana approach so that we do not end up with an Argentinian flag sign.
Okay, fine. Thank you.
Yeah. Thank you so much.
Noman, then we can go for the next one.
So now
thank you very much, sir.
Okay, Mohipal. Thank you very much for joining us. Hope to see you again. Thank you.
Yeah, sure. Thank you.
So we are waiting for the Professor Namrata. Yes.
Yes. She will come.
So I'm requesting Professor. Am I audible? Yes.
Yes.
Professor Dr.
Dr.
Mohan
Shubhat.
Rajan, sir. Hello.
Yes, sir. Yes, I'm here.
Yes. So can you please start your presentation? Sir will present on phaco in the floppy iris syndrome.
Yes, sir.
Yes.
Is my slide visible?
Yes, sir.
Yes.
Okay. Good evening to all of you.
What is your task?
Yeah. Let me thank Dr. Shams Naman for this wonderful opportunity. Dr. Sharfuddin sir and all the people from Bangladesh, all my very close friends. And it's always a pleasure to be associated with the people from Bangladesh as well. And this Indo-Bangla Phaco Fest, Overcoming the Fear, is one of the, I think, is a unique program. And what is the biggest problem in the phaco? The biggest problem is not the hard-drawn cataract or the posterior polar cataract or the pseudo-exfoliation or the subluxated cataract. The biggest problem is small pupil. The small pupil is a big problem in phaco. I'm sure Sivan is also going to cover this, but I'm going to talk to you about mainly the IFIS, the 7 steps for success as far as IFIS is concerned. What happens in IFIS? There's an alpha-1 blocker, which is used for benign prostatic hypertrophy, to treat, is also used for treat urinary retention in women also, commonly used for kidney stone management. Tamsulosin is an alpha-1 specific blocker. The identical receptor is found also in the dilated muscle of the iris. Even short-term use can lead to non-reversible, what are called iris dilatation dysfunction in some patients. The tamsulosin is given for BPH. It produces progressive intraoperative meiosis. There is an iris prolapse, billowing of the iris, which is as high as 78% of the cases. So varying from 33 to 78%, this has been reported. That is the IFIS mechanism, which has been described by David Chang way back in 2004. Tamsulosin is an alpha blocker. It relaxes the smooth muscle of the bladder neck to prevent the urinary, retention. And also the iris dilator muscle. Same time, it also relaxes the iris dilator muscles also. What happens is, in the process, it renders the ineffective dilatation drops. And that is the reason why these pupils don't dilate as well. Alpha blockers causing IFIS are terazosin, alphazosin, doxazosin. The doxazosin is also used for systemic hypertension. So many other times you will find that these people are also taking doxazosin for systemic hypertension, especially women taking this. You find that all of a sudden you'll be caught unawares on the table that you find that IFIS syndrome on the table. What happens in IFIS? You can see here when you come out of the eye, the iris also starts coming out with you. Okay, the iris starts coming out with you, and this is one of the major problems. And if you do a violent hydrodissection, you can see that the pupil is small, and you can see here, this is a mistake you should not do, wherein you try to push the iris back through the main port. So, and one of the doctors was mentioning about that. How do you see? This is a way you should not put. If you try to put the iris back through the main port using an HPMC, and this is going to see how it's going to tear the iris as well. And this is one of the major problems. You can see that this is an IFIS syndrome, wherein the iris has come through all the ports, through the main port, through the side port. And this is a major problem because the pupil becomes progressively smaller as well. You can see that the pupil is about 6 millimeter, and gradually the pupil started coming down. And if you try to push the iris back into the eye, it's going to progressively become down, and it's going to make life very difficult for you. And this is the iris dance, I call it, the iris dance. You can see your typical billowing of the iris, which is very, very typical on patients of who are on long-term tamsulosin. So what are the complications of this IFIS? The complications of small pupil, because you're not able to see well, you cannot operate well. Iris chafing, iris bleeding and iris prolapse, iododialysis, zonular dialysis, posterior capsule rupture, nucleus drop, difficulty in IOL implantation, prolonged surgical time. All these can occur. The complications can be iris trauma, and you can see iododialysis, bleeding from the iris, PCR, vitreous loss. All these can make very life very difficult, and the complications are much more than the normal patients and patients who are on tamsulosin. So number one, the secret number one or the success number one is that past or present use always do a careful preoperative protocol, that is the examination, and history taking is very important, because many patients are feeling embarrassed to tell that they are on the anti-prostate agents. You have to tell them that, are you taking any medicines for the urinary problem? Then they'll probably tell you, because they do not know that tamsulosin can cause this problem. Even many physicians also do not know that it's causing. So past or present use of alpha blockers, stopping tamsulosin will not help, because this tamsulosin is there in the blood for more than a year. Okay, so it doesn't matter. So if you stop it for a long time, it can produce severe urinary retention. So stopping actually can be a problem, especially in older patients. Atropine 3 days prior to surgery. Some of the surgeons are using it, but I find it's not very effective. Anything which is less than 6 millimeter preoperative or intra, that is before you start the surgery, can produce severe IFIS on the table. So number two is intraoperative protocols. What are the intraoperative protocols? You can use intracameral phenocaine plus, which is made by a company called Entod Plus, Entod Pharmaceuticals, wherein phenocaine plus, wherein the combination of tropicamide, preservative-free, the lidocaine, and phenylephrine as well. Intracameral epinephrine can be used. And these are the formulations you can use, either preoperative atropine 1% TID for 2 to 3 days. As I told you, some of the surgeons are using it. Intraoperative epinephrine dilute with BSS, that is 1 in 4,000 free, preservative free, which is the formulation given by Sam Masket, 1 in 20,000 preservative free, which is given by McDonald as well. And epi sugarcane or jolt sugar, which is about 3 cc preservative free lidocaine with 4% and 9 cc BSS and 4 cc of 1 in 1,000 preservative free epinephrine can also be used. But these are all for pupils which are little mid dilated and the cataract was not very hard. I'll come to the third intraoperative or the third success or the secret as far as the IFIS success is concerned. Number one, the thing is well-constructed corneal incision. So whenever I see an IFIS, I always, because I got access to the catalyst, I go for a triplanar, that is a femto incision. The femto incision gives me truly a triplanar incision, which is very difficult to make it, because you can go down and then up and then dip into the anterior chamber. That is a triplanar incision. You can make it as longer as you want. The incisions can be anterior incisions, longer incisions, lower shoulder suture, calibrated side port incision, which has been given by Rohit and Om Prakash from Amritsar. You can see this is a femto incision. Yes, sir. Can you just mute, sir? Yes. This is a femto incisions. You can see here how the femto incisions can be made as long as possible. If you want to, you can calibrate these incisions very nicely, which makes life very easy for the sake. If you have to do a manual incision, you can see here, don't make this incision very shallow. If you're going to make the incision very shallow, you need to, the iris will start coming out. Always go up on the cornea and then dip down sufficient length. For example, if you are having a 2.4 millimeter breadth of the incision, at least 1.5 to 2 millimeter length of the incision should be there. So even the side port incisions has to be a little longer and also more anterior, and this will to a certain extent prevent the iris from coming into the incisions. Intraoperative protocols, number four. Number four is, that is the fourth success is, use good OVDs. Use a sharp shell technique, which has been described by Steve Arshinoff. Shale was also describing about it. And no HPMC. When you see an IFIS, when you see a patient who's got tamsulosin, don't use HPMC. That is the hydroxy methyl propyl methyl cellulose. Because this HPMC can cause more atony of the sphincter and more IFIS. The IFIS can get aggravated. Always use Hyalon, always use Viscoat. And that is a soft shell technique which has been described by Steve Arshinoff. You can see here Once we do the hydro dissection, the irises start coming out. But once I put viscode there. I just put viscode there, and once I put the viscode there, the viscode pushes the iris back. You can see here. Once I put the viscode there, it pushes the iris back and makes the life easy. Again, all the patients with IFIS, whether it's a brown cataract or a white cataract or a grade 2 cataract, I always use trypan blue because I know exactly where my rhexis margin is. If the pupil is going to go down, I'm sure the pupil is going to go down during the surgery. I don't want to know a thing, so I want to make as a thing. I always go underneath the pupillary margin, and I always use a micro rhexis forceps. I don't use a needle, and that's what I wanted to tell Shale also. If you use a needle, you don't have control if you go underneath the iris. But if you use a capsular rhexis, utrata forceps, micro rhexis forceps, then you have better control of going underneath the iris and making the rhexis larger than the pupil size. The reason advantage of using a trypan blue rhexis is that when the pupil goes down, you know exactly where your rhexis margin is. If you don't stain the rhexis margin, that is anterior capsule, then you will have a problem of losing the rhexis as well. So this is the patient. We can see a dense brown cataract and the patient on tamsulosin. I expected the pupil to come down, and that is the reason why in the initial stages the pupil was very much dilated. I made a fairly large rhexis. So the pupil comes down. For me, the pupil size may not matter much. For me, the rhexis size matters much more than the pupil size, and that is the reason. Number six is low fluidics. If you're going to use a normal bottle height of about 100 centimeters, make it 70 or 80 centimeters for this patients. And vacuum, if you're going to use a normal of 500, 450 or 500, make it 250 millimeters. If you're going to use a normal AFR of about 40 or 45 ml, make it 25 ml per minute. Make it a slow motion phaco, decrease the fluidics, decrease the, make sure that your surgery is a little slower, doesn't matter, but you don't want the iris non-target tissues to come into the port during the phacoemulsification and make your life very, very difficult. Again, pressure management is very important. Hydrodissection, don't do violent hydrodissection. If you do violent hydrodissection and try to overfill the anterior chamber with viscoelastic, then the iris will start coming out. Once the iris starts coming out, it's becomes a very, very messy affair because it's a cascading reaction or it's something like a chain reaction. Once you start the iris comes out, you try to push the iris back, the more and more prostaglandins are released, and the iris becomes smaller and smaller in patients who are on Urimax. Switch off the irrigation when you come out of the eye. When you come out of the eye, you can push in some viscoelastic like viscode and slowly come out of the eye, but switch off the irrigation. If you come out with the irrigation, the iris will also start coming out, despite the fact that you've got a fairly good thing in patients who have got this tamsulosin. Then again, iris retractors or iris rings. My preoperative, this thing will be about 6 millimeter. If it's less than 6 millimeter, and depending on even if the cataract is a little softer, I go in for the iris hooks straight away, or malignant ring or the BX ring, which I'm using now also regularly, and whatever you're comfortable with, but do it in the beginning of the surgery. Because if you want to put the iris hooks in the middle of the surgery, when the iris becomes very small, then it's also going to be very difficult because the capsular, you do not know where your capsular rhexis margin is, and sometimes you will engage the capsular rhexis as well. So this is a single subincisional iris hook, which has been described again by David Chang. You can just put it, one subincisional iris hook to prevent the iris from coming out, and this also works very well. You can see this is the malignant ring which I'm using. The malignant ring, of course, it's a little costly, but doesn't matter. It works wonderfully well. Only thing is, if the pupil is very, very small, this malignant ring does not work. The iris hooks probably work better. And BX ring also works very well. And you can see here, this is a malignant ring. And I feel that the malignant ring also is very good, but taking out the malignant ring is more difficult than putting it inside. So this is a BX ring. You can see here, a fantastic innovation by Suven. We are so proud of this guy. And you can see that it can be put through the main port, can be removed through the side port as well, and it works wonderfully well and preventing this pupil from coming down. So what I would suggest is the take-home message is make sure that you put this iris hooks or whatever you're comfortable with, rings or whatever hooks, right in the beginning of the surgery. The beginning of the surgery, you decide, preoperatively itself, decide, okay, I'll put iris hooks for this patient in the beginning of the surgery itself. And not during, after making the hydrodissection or the pupil becoming very small, you may find it very difficult to put. Especially the Mulligan ring or even the BX ring, will find it very difficult to put it inside. So just to see I always do femto for these patients, and because it makes life easy for me. You can see here, I'm doing a femto, but you can see the iris is starting coming out. I just put viscode there and push the iris back. But what I'm trying to do is, I could have actually gone ahead with the phacoemulsification, but I decided, okay, this iris is going to come out. I just put viscode there, and immediately I went in for the iris hooks. In the beginning of the surgery itself, I put the iris hooks there. It makes, because this is a fairly hard cataract as well, and you can see here, I'm making it, the femto has made life easy for me because already the pre-chopping is there, the rexus is over, and then my iris is well retracted, and you can see that the life becomes very, very easy for us. 50% of my cataract patients are on Urimax, okay, because you can find that many of the patients are there. You find more and more patients, unless you ask for the history, the remaining 50% are on Viagra. So these are both are very, very dangerous. You have to be very careful. IFIS, better to be safe than sorry. Okay, that is the message I want to give you. The 7 steps for IFIS success will make the life easy, will make IFIS part of history. And you cannot make IFIS part of history, but you can reduce the complications and overcome that fear of having an IFIS patient, and we can produce fantastic results with patients who are on IFIS. Thank you very much for the wonderful opportunity. Stay home, stay safe, stay healthy.
Thank you, sir, for your excellent presentation, excellent videos, and you have shown how the the method of doing surgery in the IFS and taking history, pre-operative management, excellent. So I'm requesting
before
Professor
that, we have to welcome. We have to
Yes.
welcome Professor Namrata Sharma, who has already joined
Yes.
as a panelist. Thank you. Welcome. Good evening.
Welcome, Namrata.
Thank you so much.
Welcome, Namrata ma'am.
Thank you. Excellent presentation, Dr. Mohan.
Thank you.
I'm requesting Professor Ghulam Mustafa to tell something about Professor Mohan Rajan's presentation.
Dr. Mohan Raj, he nicely presented the cases. So what is my experience is, though the patients are taking tamsulosin, in some cases we find we can avoid the stretching ring, iris ring, and other things. Just using the atropine and by viscomatrix, some cases we can finish. So I want to ask Mohan Raj, what is his experience?
You want to ask me, sir?
Yes.
I am asking you.
No. I used to use atropine, sir, but I feel it's not working for my patients. And the stopping tamsulosin actually doesn't help. But actually, it's dangerous because you can produce urinary retention on the table for these patients. And this thing is, if the cataract is a little hard, if the pupil is going to go down on you, 6 millimeter is my cutoff level. And preoperatively itself, I decide, because I dilate these patients and see, then at that time itself, I'll decide, I'll make a note in my EMR saying that this patient will require iris retractors, either in the form of a Mulligan ring or a BX ring or iris hooks. Right in the beginning of the surgery, I do it because I don't want to get into a mess during the surgery. Because once the iris starts coming into the port and makes it in, then continuously it will keep coming, and it's very difficult to do a surgery, and you will end up in some complication or other. That is my personal experience.
I have something to say over here.
Yes, sir.
So I'll be addressing that in my presentation as well.
Yes.
Now, what we did 10 years back or 12 years back or 15 years back was different. And now the patient's expectations are different. The tools available to us are different. The question is, we can get away with heroic surgery. But if I had a cataract, what would I want my cataract surgeon to do? To try heroics or to play safe is the question. So you decide as a surgeon, what would you like to do? What would you like to have in your eyes when you have a cataract? Would you like the surgeon to struggle with the 4 millimeter pupil and show his heroic skills? Or would you like him to use iris hooks or an expander or anything? So that will answer all your questions about any other alternate management that you can think of.
That's right. What we have.
Yeah. Yeah.
Sir, I had
We have
just
to.
one question to you, sir. Do you
Yeah.
find any difference with IFIS or iris control when you use, say, phenylephrine combination like phenocaine
Yes.
versus just using separately adrenaline diluted?
Now we have started using this Phenocaine Plus because it's available now in the market. It's pretty good. Phenocaine Plus is a combination of tropicamide with phenylephrine. Definitely is better than the preservative-free adrenaline, in my opinion.
Have you encountered any cases of corneal edema after phenocaine?
I don't. I've not seen Namrata.
Okay.
Yeah, you have seen, is it?
I have seen a couple of cases with
Mhm.
corneal edema, but that is anecdotal because we've not, evaluated or done
Yeah.
speculoscopy study for it.
Is it endothelial toxic, ma'am? Adrenaline?
No, it's a preservative-free. It's not supposed to be endothelial toxicity, but we have
So,
used
no,
this Phenocaine Plus before also when it came first into the market. That was about 1 or 2 years back, and then subsequently they didn't get approval for that, and now it's again back into the market. We have started using it.
so the problem
Mohan
with
Rajan, you have mentioned about the epinephrine and also episugarcane.
Yeah.
How you use it?
No, it's available, sir. I have not used it, sir.
Yeah.
Epinephrine, I
Only
use. 1 in 1,000 preservative-free epinephrine is available. Yeah.
the
That is
problem is when you cannot say that a particular drug, like Shail asked just now, do you find phenocaine or phenylephrine effective? The problem is you cannot quantify IFIS.
Yes.
We have gradings and everything. So every case of IFIS is different. So it's the grade of IFIS. So the same two IFIS cases consecutively, phenylephrine may be effective in one and will not be effective in the other because the grade of IFIS will be different. So it's so difficult to say which one works and which one doesn't work. In fact, that is also something already Mohan Rajan has covered. But that's very important to remember that IFIS it's the severity of the IFIS which will dictate the extent of complications that we have.
Between the two eyes of the same patient, do you feel there's any difference, or it behaves pretty much the same way as the fellow eye if you've operated already one eye?
I think it's just that we get wiser from one and we are more cautious in the second.
Yeah. So the second appears to be more,
absolutely
easy than the first one. It always
Actually, Namrata, we did a retrospective study, and we found out that all the complications prior to about 10-15 years back in phacoemulsification were all related to small pupils. About 80% of our complications were related to small pupils. And we didn't know at that time, we didn't realize what the gravity of this IFIS problem before David Chang described it. Now we know exactly what, because at that time we didn't have much access to the iris retractors and other things also. But now we know exactly this pupil is going to come down on you, and definitely I will take the precaution right in the beginning of the surgery. That is a lesson I have learned over a period of time.
I think, sir, can I make a little comment for the beginners that I think the viscoelastic substance should be given just underneath the wound to prevent the iris prolapse, rather giving in the center of the lens.
That's what I would suggest is just use a small bolus of viscoats and just put it underneath the wound and go inside without irrigation. Go inside without irrigation, and then introduce your side instrument also without this thing. Then start your irrigation. Okay. Then when you come out also,
Dr. Shaukat Kabir, do you have any comments?
Switch off the irrigation, come out.
Yes.
Dr. Shaukat Kabir.
And during this period, you have already mentioned about the corneal wound construction, which should be longer, and that will be helpful. Yes, Shaukat.
Thank you, sir. Mohan Rajan sir rightly described the 7 steps because every step is important in case of IPS. If we follow I think his algorithm, we will be safe and our life will be easy. And for OVD, I want to like to say dispersive or cohesive OVD is always better, and we should notice the fluidics also because we have to do under low fluidics, and he's also rightly said that we have to decide prior. Also, Dr. Shubhen says that whether we small people. I have experienced some case. It was when I started this about 5 or 5.5 millimeter, but after starting, it is getting closer and it's getting normal people. So uh, for IFS, we have to use either VX or IDSUP prior, and every case we should use OVD like dispersive, and FACO will be done in slow motion FACO.
Thank you.
I think it is very much helpful for us for the 7 steps and make our life easier.
And Dr. Devashish, sir.
Yeah, I just wanted to, Mohan told, I mean, everything that he stressed the importance of, how small pupils are responsible for all our complications almost. And you should better, take precautions rather than feel sorry at the end of the day. And obviously, Shubham made the point very clear that, why should we compromise on, we should use pupil expanding devices. In cases, Mohan's cutoff is 6 mm. And of course, I realize that the other thing here, as Mohan also impressed, is the low fluidics. Now, in this low fluidics, most of us don't have active fluidics, is not to touch the iris or disturb the iris as little as possible in these cases. So, I mean, for people who have standard equipments, I would say that if we operate on continuous irrigation, if we use continuous irrigation, and if we are in foot position 1, when we are doing non-committal tasks like maybe separating the nucleus, going close to a piece, we can preserve the viscoelastic milieu in the eye, because we are not in foot position 2, we won't be aspirating the viscoelastic out. So this is one thing, which can keep the milieu with a standard equipment. If you are on continuous irrigation, you can just go to 1 or even 0, and there is continuous irrigation and the viscoelastic is preserved. So the iris is not touched, because one thing in IFIS is we should not touch the iris, obviously for the same reason. All of us recommend that we should do slow motion phaco.
Thank you. Professor Namrata, please share your experience over this.
I anecdotally again, I always feel the nylon hook should be there for IFIS cases. And the second thing is, for reasons I cannot comment, but I feel that the first choice would be the nylon hooks, followed by the BX ring, and then the Malugan ring, because Malugan ring tends to be a little rigid on the floppy iris. So I feel that BX is better than a Malugan ring, especially on a floppy iris. And I think Viscoat is a great OVD to have, or for that matter, if you don't have Viscoat, you can also probably have Helon, because otherwise the iris doesn't go back with the HPMC. So just put a blob of Viscoat there, and then you enter, like Dr. Mohan Rajan very nicely mentioned and showed also in his tips for success. So those are the things that really help. And of course, one thing is their history is very important, because like Dr. Mohan Rajan is saying, earlier we never used to, never knew about it. But now that we know, it is important to ask every patient about it.
Okay. Mohan Rajan, you have told that if we use the Malugan ring, if you introduce it easily, but if you remove, it is so hard. How can you make it easier?
No, the Malugan ring, I feel the removal of the Malugan ring is more problematic than putting the Malugan ring. But however, with the experience, only thing is you need to make sure that you dislodge all the eyelets from all the three, that is the inferior and as well as both the sides, the temporal and nasal ones, and then try to engage. And same injector can be used to remove the Malugan.
Yeah.
Thank you all for the
learning curve.
Yeah.
Thank you everybody for the nice discussion about the topics. Now I'm requesting Dr. Shubhen Bhattacharya to start his presentation on phacoemulsification in the rigid people.
Can I share my screen?
Yes.
Can you allow me to share my screen?
Start.
Yes.
Yeah.
I can't see share screen. I can't see the share screen option.
Yes, you can. You can.
No, not yet.
Not yet. I don't see the share screen option.
No,
Yes,
no.
can you
Oh yeah. Okay. Yeah.
Pull it up. Pull it up.
Yeah. I'm there.
Pull the whole screen up.
Yes. I can see it now.
Yes.
Yeah.
Thank you. It's coming.
So yes.
Yeah, that's okay.
Yeah. Can you see my screen, please?
Yes, sir.
Yes.
Okay. I'll just now change this to. Sorry. So I'm Suben Bhattacharjee, and I will be speaking on FICO and small people. It's a huge topic. So now this is my financial disclosure. I gain, my company does gain from financially, though I don't myself gain right now from the BX People Expander. And I'm thankful to Dr. Neto, Dr. Deepak, and Dr. Ajoy for lending their videos for this presentation. They're great friends. And so I've divided my presentation into basically certain topics where there's a part called preparation and there'll be a part called implementation. So in preparation, we talk of preoperative NSAIDs. And like we were just discussing, and Dr. Mohan Rajan has beautifully covered IFIS. So that has made, he set the stage for me to go on with the rest of the talk. What I would say is every eye is an IFIS candidate, and with the preparation is in the mind. Let's give ourselves, our egos a break. And we need to reduce our threshold for using a pupil expansion device. Today 2020, the scenario is very different. Patient expectations are different, and the margin of forgiveness is very little. We need to release posterior synechia and peripapillary membranes completely. Intracameral injection of combination mydriatics and local anesthetics. We just discussed that. And what's most important is test and distinguish the elastic from the non-elastic rigid pupil. That's something I'll be discussing at length. Now, when we come to implementation, once we've decided whether it's an elastic pupil and a rigid pupil, we decide on the tool that we're going to use. We could decide whether we want to use OVD, iris hooks, or pupil expander, depending on the experience and the nature of the pupil that is there. So I'll be talking about a little bit of iris hook tips, pupil expander tips, and then post-op medications. So now preoperative NSAIDs, there's a wonderful paper in JCRS in 2018. The take-home message over here was pre-op NSAIDs inhibit surgically induced meiosis due to iris manipulation and prostaglandin release. There is no evidence that they augment pupil dilatation alone. So we must remember that it does not help in mydriasis. It just prevents intra-op meiosis. So Professor Mohan Rajan covered IFIS very well. So what I will just come to is the brass tacks. And I would look at IFIS as two components: meiosis and iris prolapse. Iris hooks and pupil expanders, what they do is provide a constant pupil size, provide good visibility for safe phacoemulsification. So whether you use iris hooks or pupil expanders doesn't matter. When you come to iris prolapse, no device actually helps. Iris prolapse depends on the IFIS severity and pathological damage to the iris, stroma, and muscles. So there is no credit to the pupil device when you don't have iris prolapse. It's just lower grade IFIS. So you might get away in one case and you may not get away in another case. So what we need is small incisions, which causes less leak. We need thin, low vertical profile device so that more space is available in the AC for us to work. And we need a device which can exit through the side port, preferably, because iris will be prolapsing from any port that you're working on. And this is a lovely article by Chang and Campbell about IFIS. So what is mentioned over here is, unlike the non-elastic myotic pupil, the IFIS pupil immediately snaps back to its original size. That means the IFIS pupil is an elastic pupil. So we need to differentiate the elastic from the rigid pupil. Elastic pupil is like a rubber band, and any device will work. The rigid pupil is not stretchable, it's tearable. So a strong and bulky pupil expander will be required, or you need to mechanically kind of tear that fibrous ring. So pupil stretching is not effective in IFIS. It's an elastic pupil, like we discussed. And controlled stretching we need before a pupil expander if it's a rigid pupil or a fibrotic pupil. So you have the iris hooks and the iris retractors, and the Mulligan ring and the BX pupil expander. So the choice of pupil expander will depend upon how you wish to tear the rigid or non-elastic pupil. That's the bottom line. So if you're willing to do it with the two Coughlin hooks, you could cause controlled tears, which will result in a round pupil. You can use the BX. It's a hair-thin device, and it occupies very little space in the antechamber. Or if you want to tear it with the pupil expander, you would like to use a Mulligan ring or an APX or an I ring. It's a bulky device and it'll occupy a lot of space in the AC, and it obstructs movement of instruments in the AC. So how do you check for elasticity of the pupil? And we need to do that before we start the case. So just after we made the paracentesis, just inject BSS from the side port and you watch that pupil. If it expands, then it's an elastic pupil. It's not fibrotic. So now a fibrotic or a rigid pupil is not expansile. You cannot kind of expand it even if you inflate the AC. So you need to stretch it a little bit. And once you stretch it, now it becomes a little expandable, so-called. You actually turn the pupil sphincter or the fibrotic margin over there. And now you have a pupil which will allow you to use iris hooks or a pupil expansion device easily. So let's look at this. This is Dr. Nato's surgery. Look at this fibrotic ring removal, and he swept that iris, the spatula under the iris. And once he removed the fibrotic ring, then he could place the BHEX pupil expander and get a wonderful 5.5 millimeter pupil, which allows safe visualization and safe phacoemulsification. So every step becomes easy once you have visibility. Now, the next case is an extreme case. Sorry.
Mustafa, unmute karo. Mustafa, make yourself unmute. Mute, Mustafa. Mute.
Yeah. So this is a rigid pupil, and look at the size of the pupil. Nobody would believe that you could use a BHEX over here. So yet you can get away with it because this is now once the fibrotic membrane or the peripupillary membrane is removed, it renders the pupil elastic, and just with the bimanual technique using an iris hook or a metallic iris hook, you can use bimanually and use the BHEX ring, and then you have a wonderful mydriasis. So you saw it was just almost a 2 millimeter pupil, and you have a wonderfully round pupil at the end of surgery. So how big you want the pupil to be is your choice. Actually, it's more psychological. If we were, since we have discussed that all of us are comfortable, you see, we take that call when it's about 5.5. So if you're assured that the pupil is not going to come down below 5.5, I think that should be good enough. So any device which gives you a 5.5 millimeter pupil should be good enough for all of us because we've got excellent fluidics and we've got excellent skills. Now, this is a rigid pupil, a hard cataract, pseudoexfoliation, and a 5.5 millimeter pupil is good enough for surgery. This is Dr. Deepak Megur's surgery. Of course, he's a wonderful surgeon and a great educator. And you can see the hardness of the cataract. It's a pretty hard cataract. Chopping is so easy. Yes, in a hard cataract, we need to chop the nucleus into smaller fragments for easier delivery. And of course, it's very easy to remove the BHEX through any of the incisions. Intraoperative myosis is a problem always, and that's when we need to be very judicious in the choice of a device. Just inject a little viscoelastic under the pupil margin and just over the capsular rim. That creates that space. And as you tuck those flanges, you have instant confirmation. As you push that flange towards the periphery, you have instant confirmation that you have not engaged the capsular excess margin. That's a huge blessing with the BHEX pupil expander because you're doing it under direct visualization and you're very safe throughout. This is in flax, you have an issue of intraop myosis. I believe it was I do not have personal first-hand experience with flax, but I believe this was more of a problem earlier, and nowadays it's less. But in this paper in 2018, the mean pupil area decreased by 29, almost 30%, and this was correlated with duration of laser pretreatment, laser capsulotomy, pupil margin distance, and the patient's age. So this is a surgery by Dr. Ajay Paul. He started off with a pretty small pupil and thought he would get away. So he went ahead and did the capsulotomy with the femtosecond laser. And then when he was in the surgery, realized that after he removed the capsular flap, he realized that the pupil wasn't really favorable enough for safe phacoemulsification. So went ahead and used a BHEX pupil expander, just as good as an intraop myosis in a phaco, and it was very safe, and he could complete the surgery safely. So in flax, when you have intraop myosis, or even preoperatively, it would be pretty useful. And that's the IOL implantation, and pretty safe. You have good visibility. So viscoelastic, now this is a basic step which we must understand, especially for beginners, where and how much to inject for iris hooks or pupil expander, doesn't really matter. Now, invariably, when we start with a small pupil case, we are tempted to inject a lot of viscoelastic in the antechamber to inflate the antechamber to get a larger pupil. Well, that is a tendency which we need to avoid, because if you have decided what we are going to use, if you have decided that you're going to use a pupil device, then you need to keep the antechamber shallow. So when you inject viscoelastic, you're actually plastering the iris on the anterior lens capsule, and you make life difficult. Instead, if you inject viscoelastic under the pupil margin a little, and keep the anterior chamber actually just a little bit in the anterior chamber, so that the anterior chamber is shallow, and you lift off that pupil margin from the anterior lens capsule, you have space for the iris hooks and the flanges of the pupil expander. So, and the anterior bowing of the iris helps us very much in hooking the iris with the iris hooks or tucking the flanges. So let's see a few tips. This is a pretty old video, so we make the side force first. We do not overfill, as I said. The paracentis should be in clear corner incision and posterior directed. 0.5 millimeters sufficient. And I would prefer to leave a conjunctival mark, because sometimes it gets pretty embarrassing as we cannot find those small incisions. So you need to retract the stopper far enough, hold the hook sideways or posteriorly, and do not pull the iris all the way. Don't pull out the phaco incision and wait only after the iris retractor is in place. And the capsular rhexis, we should avoid the temptation to make a large capsular rhexis, because we have a large pupil now. Because we tend to kind of, in this case also, this is a pretty old case, so we were tempted to make it as that. And we must remember that the pupil has now come to the limbal plane. So it's anti-flexed, and this will obstruct instruments and can get damaged. When we are removing it, we just need to hold that stopper and advance that iris hook a little. And once it's clear the pupil margin, just draw it out, and it just kind of straightens out temporarily, and it's easy. It just walks out of the incision. So, and this is the Oettingen Omfrey technique, where you use a diamond-shaped pupil with one hook under subincisional. Sorry for the quality of the video, it's very old. A few pearls. Now, we must avoid this tendency for over-retraction. This was a fibrotic pupil, and I didn't really recognize it at that time. So I'm practically drawn the entire pupil to one side, and look at that sphincter tear. As soon as now the third hook, when I am drawing it, and we have a huge sphincter tear, which was really cosmetically. But this is an important tip. If you're going to use the iris hook after your capsular rhexis, it's best to use a second instrument and just lift the iris pupil margin to tent it, and then you cleared the rhexis margin, and you can place that iris hook very safely. That's a very important tip if you're using it after the capsular rhexis. Now, post-operatively, this is a good paper, and again, in Acta Ophthalmologica, which appeared in 2018, I think. The take-home message over here was, use of pupil expansion devices may predispose eyes to increased risk of clinically significant CME, pseudophakic CME, and we need to use NSAIDs, preferably in the follow-up treatment. I would encourage all of you to look up this article that I've written in eOphtha. It's 10 tips for phacoemulsification in small pupil. It's a very comprehensive article with a lot of references. Thank you very much to the Bangladesh Ophthalmic Society and the Bangladesh Ophthalmic Forum for this kind invitation.
Thank you, Dr. Shubin, for your excellent innovation. Congratulations for this innovation.
Thank you.
I think it is doing just great. And thank you for these nice videos. And now it's the time for the discussion. So I'm requesting first Dr. Devashish sir to tell something about this. What is your experience over this BX ring?
Yeah, I mean, we have been using Shubhen's BX for a long time now. And Professor Sarfuddin was asking about the removal of Malaguin ring. So BX is very easy to remove.
Yeah.
You can just pull it out. So that is one of the biggest advantages. The second biggest advantage of BX is that you can implant a BX, as Shubhen said. I mean, most of the time you start a surgery and you see that the pupil is good enough and you can get away with it. But during the course of surgery, you see that the pupil has come down. And this is the time when you have a rhexis and you want to put a pupil expander. in this situation, I think Shubhen's BHEX is a wonderful, wonderful device. And you must actually put dispersive viscoelastic between the iris and the capsulorhexis. I mean, not within the capsulorhexis, not in the anterior chamber. So that requires a little care. And the third thing is, I think Shubhen should make it available in Bangladesh.
It's
It
already
is
available.
it is a very inexpensive device. So, I mean, a Malaguin ring costs a hell lot of money. If you say the disadvantages, probably the Malaguin is more sturdy. So maybe some people say that it gives a better dilatation, and probably the strut support on the iris is a little more. But we find that for all practicalities, BHEX is a wonderful device, because you exactly need 5.5. You don't need more than that. Yes. And that gives and it is you have so much space, because Malaguin ring being bulky, I mean, it sits in the eye. It definitely prevents the iris from going here and there. But at the same time, it occupies a lot of space. So all taken together, I think we go with BHEX, and I think BHEX is a wonderful device.
Thank you. Thank you.
Can I just add a comment over here?
Yes.
To address Devashish's question, and actually the fact that people believe that the Mulligan ring provides a larger dilatation is something. I'll just show you a video if you'll allow me to share my screen again. So not video, actually an image.
What's your choice for pinpoint pupils?
Yeah, can you see this image?
Yes, we can.
It's a Mulligan ring and it's a BHEX superimposed on it. Tell me which is larger.
Okay, almost same.
It's the same. So the 6.25 that the Mulligan is talked about is the external dimension of the Mulligan ring. The BHEX from flange to flange is 6.5 millimeters. So if you take away the notches and the scrolls of the Mulligan ring, the effective pupil dilatation is 5.5 millimeters for both the devices. There is no difference. Yes, the Mulligan, Boris is a lot stronger than me. So the Mulligan is a stronger ring in that sense.
So what about the pinpoint people? What Professor Dr. Mohan Rajan has asked you?
See, pinpoint, like I said, I showed you a video. Where the pupil had become almost 2 millimeters. It's not the pinpoint. It's whether it's an elastic or a rigid pupil. So if it's an elastic pinpoint pupil, like I showed the second Dr. Nito's video, it had come down to 2 millimeters. So that really doesn't matter. Once you have tested that it's an elastic pupil, it will stretch with any device that you use. But if it's a rigid pupil, you need to make it stretchable. So you need to kind of break that fibrosis. If fibrosis is like a string, it's not a rubber band. So you cannot stretch it. You can only tear it. So once you get rid of that fibrosis, only then you can use it. So the size is not important. It's the nature of the small pupil, whether it's an elastic or non-elastic. That's what is more important.
Thank you. Professor Dr. Anisur Rahman Anjum, are you there? Dr. Anisur Rahman? Hello?
No.
So, Madam, Professor Narmata Sharma, please.
So, like I said, I've tried it in a couple of cases with corneal haze also. And when I took BHEX, and so when I told him that we would try, I feel BHEX is easy to, to the wound it goes easily, and it is easy to put, because if you look at BHEX, it is a little more flexible than Malaguin ring. So the consistency of that is, similar to what your iris is. So Malaguin is like a little bit of an overkill, for a structure like iris. So I feel that BHEX that way, matches the same wavelength or has the same tuning as the iris, and so it is easy to put in, easy to take out. And also I feel in femtosecond, when you're doing femtosecond laser, then in those cases, and you have intraop meiosis, you're always scared, and especially in cases of small pupil, if you put the BHEX ring, it is a lot more easier to do, your femto capsular X's also and your chops also, as opposed to, of course, with the nylon hooks, it's always a dilemma whether it will happen completely or not. But with BX, that's not a problem. It does happen with Malugun also, but I feel because uh, more comfortable with BX.
Dr. Shail, do you have any comments?
No, I think I have very limited experience with the BHEX, but it's been an excellent experience so far. Over my training, iris retractors is something I trained on. So still, my primary would still be at present iris hooks, but I'm sure we would all be shifting to these newer devices sooner rather than later. The probable only place where I would think, particularly for beginners, it might be easier to get trained with iris hooks is using them intraoperatively once the capsular X's and other things are done. So the only advantage I see of iris hooks is that even if inadvertently you go and catch the capsule, you anyway do that during subluxated lens removal. You use the same iris hooks to hook the capsular bag. So at least that risk factor is probably slightly less, but I think that would probably the BHEX would also be with experience be easy to insert intraoperatively by just injecting dispersive viscoelastic behind the iris to separate it from the capsular bag. So I think it's more a matter of getting used to one particular device than the other.
Yes, sir.
Okay.
Very nice presentation.
Very nice.
Suvan.
Do you have any comments from anybody?
I'll make a comment, Naman. No, I just want to compliment Suvan for the wonderful innovation first. And no, he is the one who actually opened our eyes to say that 5.5 millimeter is good enough to do a fairly good phacoemulsification. As long as the iris doesn't come into your port, doesn't matter. 5.5 millimeter is good enough. The only thing is when you're using the iris hooks, many people still use the iris hook for comfort because they're used to that. They don't want to change or something like that. But I would suggest that if you use the iris hooks, make sure that you are in the limbal plane, okay? When the stab incisions, don't put it anterior. If you put it anterior, the whole iris will start tenting up. So put it in the limbal things, in the stab incisions, so that you can have a tangential retraction. Don't keep the iris retracted for too long a time and too much of traction. So once you remove the nucleus, for the cortical aspiration, you can just relax the iris hooks a little so that you don't tear the iris too much. And for very small people, still I would suggest, I'm not sure, because whenever I stretch a pupil, it becomes a little atonic, it becomes a little loose for me. But I want to know the experience of Suven also. Namrata, do you stretch the pupils as well?
No, I don't, stretch it too much. And one case that like Suven showed, that if you, stretch it on one side with a nylon hook and then you stretch it, what I tend to do is I tend to put all the 4 hooks inside first and then very gradually,
fully stretch it.
very gradually stretch it on 2 opposite meridians rather than, on one meridian. So it kind of, and it doesn't remain stretched in one direction for too long, unattended by the opposite meridian.
Or you put the fifth one, the fifth iris hooks you can put probably. If you find that 4 stretching too much, you can probably use the fifth. Many cases I've used the fifth iris hooks also, and it works wonderfully well.
I think Dr. Mohan Rajan has brought out a very important point, is that actually when we're using iris hooks, we have a tendency, we want to see the pupil as large as we can. Okay, so we tend to overstretch the pupil. And if you realize, the corners outside the capsular X's margin is actually wasted space.
Absolutely.
Really not putting that space to any use. So that is why actually you have, when you said that you use 5 hooks, you actually made it a pentagon. So I've given you a hexagon.
Hexagon. Okay,
so
fine.
actually,
you are one step above everybody, man.
Yeah.
Come on.
you ask it and you name it and I'll give it to you.
Yeah, thank you. I have a question to Shubhen.
Yes, sir.
One question is that you have mentioned that if we use the pupil expander, there is the pseudophakic cystoid macular edema.
Yes, sir.
Which one causes much more among the 3 pupil expanders, Malugan ring, iris hook, or BHEX?
The study did not differentiate. Actually, the study did not include BHEX anyway. it had, because BX was not available in those markets.
Yes.
So it is only mostly on Malugan ring and iris hook, but it's basically prostaglandin release. So if you're going to use a device, it is going to manipulate the iris, and you're going to have prostaglandin release, and there is going to be a break of the blood aqueous barrier, and there is going to be CME. So, but the question is, if you don't use a device, you could traumatize the iris and still have the same result.
Sure.
Yes.
Sure. So, to prevent
it is a
we have to
two-edged
use
sword.
the NSAID
If you use the
earlier
NSAID
and later.
preoperatively,
Yes.
you might have some benefit, but there is no RCT. So on that.
So, Dr. Devashish, sir.
Yeah.
Yes,
I just wanted to, about that paper, Shubhen.
Yes.
You say cystoid macular edema. Did that study have a control where the pupil expanders or the iris hooks were not used?
Yes, I think yes, it did.
Okay, because as such, a small pupil case would have some thing.
Exactly what I'm saying.
Or manipulation. So whether we use a ring or a hook, does a CME?
That's what I'm saying. If it was say 6 millimeter pupil where they had no IFIS and you did not touch the iris, well, you'll get away with no CME. It's just like any other ordinary case.
Thank you. Thank you, everybody. We are in short of time. We will get 1 minute's time for everybody to give a comments of this over this webinar. I'm requesting Dr. Shaukat Kabir for the next 1 minute.
1 minute.
Thank you. I'd like to thank all the speakers, because we have learned a lot, and we can make ourselves much more refined.
Yes. Fine. Next.
I think he's out of.
Professor Mustafa.
Professor Mustafa. Hello.
Dr. Ghulam Mustafa.
Dr. Ghulam Mustafa.
Okay, he's no more. Dr. Anisur Rahman.
Dr. Anisur Rahman.
Can you have any comment? No. Then we can go to Dr. Shal Bhasabada.
Yes. I think it was a fantastic webinar, and I think the best part was it was extremely interactive, and there was so much time for discussion that all possible points related to the topics were covered beautifully. And I cannot thank the organizing team enough for creating this wonderful webinar. Thank you.
Thank you. Next, Shubhen. Dr. Shubhen.
Thank you, Dr. Noman, Professor Sharfuddin, and Professor Ghulam Mustafa, Professor Shaukat Kabir, Professor Anisur, for inviting us. It's a pleasure always to discuss things across the border.
Yeah,
it's fun. We share similar cultures and similar patient profiles. So it's a lot. We have common interests, and it's always fun to discuss. Thank you so much for this opportunity.
Dr. Ghulam Mustafa, have you got any? Dr. Mustafa, 1 minute comment. Comment for 1 minute. Yes.
So it was a very nice session. It was very much informative. So those who are beginners, our residents, I think they have been benefited. Also, our regular faculty surgeon, those who are working, they also have been benefited. So thank you all for this. And also, I would like to thank those who have arranged this nice session.
Thank you.
Thank you.
Professor Mohan Rajan.
I think it is a very, very useful, very informative. I learned a lot of take-home messages. And what is important is, I think Dr. Nouman, Dr. Sharfuddin, and all the people, you had only 4 speakers.
Yes.
You covered all the topics, and you had a lot of discussion. Because many people want to clear the doubts. In many webinars, we have 10 speakers. We are not able to finish the topics, and we don't have proper discussion also. I think we discussed in length and breadth about each and every topic, and all the doubts were very clear. It can be a very basic doubt or a very advanced doubt, but whatever it is, we need to clear that. And I think we are going all with a very clear mind, clear take-home message. Thank you very much. Wonderful opportunity.
Dr. Debashish Bhattacharya. Dada.
Yeah. Thank you. And it was nice to be amongst friends. Professor Sharfuddin, Professor Mustafa, Noman, of course, and Shaukat and everybody. So thank you very much. It was, as said by everybody, it was very interactive, which was the very essence. And all the presenters did a fantastic job. Kail, Maipal, Mohan, Subin, they really hit every point that was relevant. I think we all benefited. I learned a lot personally. Thank you very much.
Thank you.
And last not the least, our Didi, Professor Namrata Sharma.
I call her Amma. You call her Didi, I call her Amma. Whenever she comes to Tamil Nadu, I call her Amma.
So much for having me. Like I said earlier, that in normal times I did not visit Bangladesh more than 2 times, and in last 1 month or a couple of months or during the COVID times already, this must be my fifth or sixth visit. So
Yes.
this is what the virtual platform has done to us, and thank you, Noman, for being the dynamo of Ophthalmological Society of Bangladesh along with Bangladesh Ophthalmic Research Forum. Thank you, Professor Shafruddin Ahmed, sir. It's always been, wonderful coming here, and it's been a long association with you. Never did I realize many years ago that, this will turn up like this. And thank you so much, Professor Ghulam Mustafa and Dr. Shaukat Kabir. The presentations were excellent, and it was wonderful to be a part of.
Thank you.
Thank you. So I'm
Thank you.
requesting Professor Sharfuddin Ahmed to give his speech and end up the session.
Okay. Thank you very much, Dr. Noman, for your hard work for this successful webinar. I am very much grateful to all the panelists, Professor Namrata Sharma, Dr. Debashish Bhattacharya, Professor Ghulam Mustafa, Dr. Shaukat Kobi, Dr. Anisur Rahman, and also the main speakers, Professor Mohipal Shazdev, who joined us, and he has given a talk on Pas Plana 23 trochen cannula user in case of some complicated phaco surgery. Dr. Professor Mohan Rajan in floppy iris syndrome, and also Dr. Shail Bhasabhada. He told very nicely the things what type of experience he got in pseudo exfoliation syndrome. How did he use the endocapsular ring, and in case of hydrodissection, how much, what was the problems in hard rotation in jonular dialysis was done, and he told about the POPs. I'm very glad to learn from him about the position, and also occlude in the low vacuum, posterior detachment, and lastly swell. Very good. And I think all the talks, Dr. Mohan Rajan, Dr. Shail Prasabhada, and B. Hicks, I think Shubhan Bhattacharya and Mohipal Shazdev, you have enriched our knowledge in such a situation that this record, this webinar has been recorded, and I hope this will be very much helpful for our residents and also the ophthalmologists who also have some doubt in some cases how they will handle during pre-operatively or during operation, or how they will use some drugs pre-operatively or post-operatively. I think this webinar has given us a lot of knowledge. I hope you have given much more time, even in your busy schedule, as we are out of our cross border. It's a global village. We are in the same screen now, and we are very nearer, not 1 inch difference from one to another one. I hope in future this type of webinar will be arranged, and you will join with us, and you will enrich the knowledge again and again to all the ophthalmologists and our residents. I hope with these few words, I will thank you very much. I thank Dr. Noman, as because he has arranged this thing very with a hard work, I think so. Thank you very much. And in very near future, we'll meet together when COVID will not be with us. I will hope that you will be in healthy life, you will be safe, and you will be have a long, healthy life. Thank you very much. for
Thank
joining
you.
us. Thank you.
Thank you.
With these
Thank
few
you.
words, I conclude this webinar.
Sir.
Thank you.
Thank you, Dr. Noman.
Thank you, sir. Thank you, sir.
Thank you.
Assalamu alaikum.
Thank you, everyone.
Assalamu alaikum.
Take care. Good night.
Good night, everyone.
Take care, sir.
Okay. Thank you.
Thank you.
Thank you.
Okay.
Thank you, Namrata ma'am. Thank you, Devashi sir.
Thank you,
Bye-bye.
Ramota ma'am.
Thank you,
Thank you,
Said.
Shail.
Thank you.